Well, hello, everyone, and welcome to the first of the year and our first major event of Myeloma Action Month, to this virtual community workshop hosted by the International Myeloma Foundation, where we are celebrating our 35th anniversary, as you see here, defying boundaries and redefining possibilities. Hi, everybody. This is Dr. Joe, as many call me, or Joe Mikhael. I'm a myeloma physician. I have the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation, and I will serve as your host tonight. So sorry you're going to hear my voice a little bit, but as I frequently say and appropriately say, I'm really just going to be the appetizer. The main dish is coming with our three outstanding speakers that we have with us tonight. So whether you're watching this live or watching a rebroadcast, we really hope that this is going to help you in your journey with multiple myeloma. We've entitled tonight's program, I Have What? Starting the Myeloma Journey. Some of you may be familiar that in the past, we often had community workshops where we covered everything there was to do in myeloma and squeezed it into 2.5 or 3 hours. Well, this year we're going to break it up a little bit. We've got our first community workshop tonight focusing on frontline therapy. In July, we're going to have one focused on relapse therapy. And late in the year, we're going to have one that is focused on the controversies or big questions that we have in multiple myeloma. But for tonight, the focus is going to be earlier therapy. So whether you were diagnosed today or in the last year or two, we trust this will help you to think through the disease, understand it better, and to know that the IMF is in your corner. And we work with extraordinary individuals like the physicians and nurse practitioners with us here tonight. And let me quickly introduce them to you as we walk through the agenda. So after I've given a few more welcome comments and explained to you how you can submit questions and the like, I'm going to give us just a little walk through what we often call the Myeloma 101. What are the basics? Now, no matter where you are in your myeloma journey, I really think this will help you, because whether it's for your understanding or frankly, as you try to explain this to your family, as you explain this to other people in your network, very often they're like, myeloma, is that a skin cancer? So we have to explain the difference between it. And so I'll spend some time going over the basics and hopefully bring you up to speed. And part of the Myeloma 101 is really to get you excited about some of the new kinds of treatments that we have, the kinds of things that, Dr. Braunstein and Dr. Rajay and Mary Steinbach are doing on a regular basis. And you're going to hear a bit about that in the 101. Then I'm going to pass it over to Dr. Braunstein, who comes to us from NYU in Long Island. And he is going to talk about those patients that are typically not going to autologous stem cell transplant. We still, generally speaking, and I'm sure this may come up with the questions, and I know Dr. Rajay has got some feelings about this. We still, generally speaking, divide people into transplant eligible and ineligible, but is that always going to be the way we're doing it? Maybe we're going to talk about quad eligible or ineligible, but I don't want to steal any of his thunder. We're really looking forward to his input in explaining that to us. We'll then have some time for Q&A. So, and I'll explain to you in a moment how you can enter your questions. We'll take a little bit of a break. I'm a hematologist. No one in our program should get a deep vein thrombosis or a DVT, so everybody will get up and get a little bit of a break, get some fluid into them, and then we'll come back, and Dr. Rajay will walk us through what do we do in patients who are planned to go to an autologous stem cell transplant. She'll walk through some of the principles of how we treat this and what exactly are the options that we have for patients. And of course, Dr. Rajay needs no introduction. She's been with us on many programs before, but she directs the Center for Multiple Myeloma at Mass General in Boston. Which is probably a little bit cooler than where I am right now, Nupur. So I see you're drinking some warm tea there. So don't get cold. We need you warm. And then lastly, it's always a joy to share the stage with Mary Steinbach. And Mary is just fantastic. She not only cares for patients in the clinic. She has so much to do with our support group. She sits on our Nurse Leadership Board, and she is going to talk to us about living your best myeloma life, how we manage side effects, and how we empower our patients. This is absolutely fundamental because our vision at the IMF is a world where every myeloma patient lives life to the full, unburdened by the disease. We want them to live a great life. I say it all the time. I don't treat myeloma, I treat people. And Mary is going to remind us about how we remember that we're not just a carrier of plasma cells, but that we are real people and how we manage that. And then we'll take some time for Q&A before we close off. So that's our agenda over the next 2.5 or so hours. I will now show you that on your screen, you have the opportunity to open that Q&A window, and it gives you a chance to submit some questions. In fact, some of you knew this was coming, and several questions have already been submitted to me in advance. So we already have a big pool of questions, and more of them will come in through the chat tonight. And then please, I will note that we can't always answer every question, but nonetheless, we keep track of them. If you engage with the IMF in any social media platform we have, add the hashtag #AskTheIMF, and we will work on answering that question for you. And of course, if it's a more personal question and you want to have it addressed individually, then please reach out to our info line. We have an info line that's active every day and electronically is active all the time. And of course, you can always ask Myelo. Myelo is our chat bot that is live now on the myeloma.org website. So if you go to myeloma.org and ask Myelo, you will be sure to get some great answers. As I've noted, that this is being not only watched in live, but many will watch this in perpetuity. And if you go to the myeloma.org webpage, as you see here, and you look under publications and videos, you'll see the opportunity to retrieve this video and share it with others and watch it again in the future if you need to. And of course, as always, as I noted, we made a change to our format this year and included 3 different community workshops as opposed to repeating the same workshop 3 times. And that was based on your feedback. So if you have feedback for us, you'll see that there's going to be an opportunity to fill out a survey at the end of the meeting. And we really, really appreciate your help with that. I'll comment on that one more time. I'd like to take a moment to thank specifically our sponsors for tonight's event, GSK, Johnson & Johnson, Karyopharm Therapeutics, and Takeda, who supported us in ensuring that we can do this. I mentioned quickly at the start that this is Myeloma Action Month. It's more than an awareness month. Awareness is good, action is better. And as you can see here, there are lots of other things that we can do. And action doesn't necessarily mean that you climb a mountain for myeloma, and maybe that's a good thing you can do. But for many, it's taking one of these steps. Sometimes it's just sharing your story with others, engaging with the IMF, supporting the events and the activities that we have, helping people know myeloma. We've often used that know, K-N-O-W, but also N-O to myeloma. We want to put an end to myeloma. And so if you go to myelomaactionmonth.org, you'll learn more of these options, and we can give you a little frame electronically or physically that you can hold up and make a comment about myeloma. I saw many people doing that today on social media, and it warmed my heart. And lastly, I'll just remind us that we are celebrating this year. We're going to have a celebration later in the year that the IMF has been around for 35 years, founded by Dr. Tuohy and Susie Novus and her husband, Brian Novus. It's hard to believe it's been 35 years now, but we have been in business for 35 years, and we'll celebrate that as we have the privilege of caring for patients all over the planet. With that introduction, I want to just turn to the other 3 speakers and say in particular, welcome, Marc, welcome, Nupur, welcome, Mary. We're so happy to see your faces. We're thankful that you're with us tonight. Very much look forward to hearing from you in a short time. All right, let's dive into Myeloma 101. So I suspect that many of you are familiar with this, but let me tell you what I plan to share with you over the next 25 to 30 minutes, which is first of all, just to review the basics of blood and cancer. Sometimes people find it difficult to fit myeloma into the bigger picture. So we're going to start uber basic, and then we're going to get into define myeloma, discuss a little bit about how we classify and think of myeloma, and then really just think about the basics of treatment. Obviously, our speakers tonight will share much more about how we treat, but I'll just give you that sort of overview strategy. So how common is myeloma? Well, we expect around 36,000 new cases this year. It accounts for a little under 2% of all cancers. The average age of diagnosis is about 69, but we know that there's a huge variation within that. Indeed, individuals like myself of African descent or individuals of Latino background tend to be diagnosed 4 to 5 years younger. We do know that it is a little bit more common in men than in women, and it's twice as common for those of us of African descent. And so that's an important concept that we're going to, come back to at different points. I do obviously a separate lecture series on health disparities in myeloma. Myeloma is the most disparate cancer within the Black population, meaning a Black man or Black woman diagnosed today is expected to live half as long as the same aged white man, white woman. And obviously that's entirely unacceptable. And one of the reasons why the IMF is working so hard to help overcome that. But in terms of sheer numbers, as you see here, it puts myeloma in about the 14th cancer in the list of cancers in terms of their incidence. And again, with the age distribution that you can see there in the bottom right-hand corner, the vast majority of people with myeloma are between the age of 45 and up, but there are some cases very young that we occasionally see. So that gives you just a little overview of how common it is. But one of the most common questions we get, and I'm sure Mary, Marc, Nupur, you can agree to this in your own context, we often get asked, what causes myeloma? And I'll start at the right hand of the slide, where in most cases, honestly, we really don't know. We're studying this, we're trying to learn it. We're learning a lot about, as I've noted, as we get older and our plasma cells get a little bit older, and I'll explain what plasma cells are in a moment, we know that things can happen that can lead to myeloma. We know that there are some associations, like many cancers, are an association with obesity that we haven't fully understood. We know that there are families where there are many more cases of myeloma than one would expect for a rare disease. So there's clearly a familial component. And yet most people with myeloma don't have a family member with myeloma. So we still haven't sorted out. We hope that some of the work that we're doing in Iceland will unlock some of the genetics of myeloma. And then, of course, there are some patients that we have come to appreciate that it is likely connected to certain exposures, in particular for Agent Orange in our veterans who've been exposed to it, or those who have potentially been exposed to things like burn pits and very high exposure to pesticides and herbicides. Interestingly, we saw increased incidence of MGUS, not so much in patients who are in the farmers, for example, but it was more the crop dusters, the individuals who were flying the planes back in the day that had huge amounts of pesticide within them. But again, we think this accounts for a very small percentage of those patients with multiple myeloma. So for most people who have myeloma, we literally say, you didn't earn this. Unfortunately, it happened, but we are trying to understand its origin a little bit more. One other thing that I think is really important is as we're going to see, very rarely do we truly pick up myeloma before it's caused some grief. We think someday we might screen for myeloma like we do for breast cancer and colon cancer, but we're not there yet. And so sadly, myeloma doesn't really have one sign or symptom that points us in the direction to say that someone has myeloma. About a third of patients present with fatigue, and not just regular fatigue. I mean, this is fatigue way out of keeping of normal. Who of us have not been fatigued even today? We don't want everybody to be paranoid about myeloma, but fatigue that is persistent and goes beyond the usual. People who have bone pain, not always in the back as in the picture here, most commonly in the back, but it could be in other places, because as I'll share with us in a moment, unfortunately, myeloma does affect the bones. And then about 3/4 of patients have anemia or a low red blood cell count, if indeed the blood test has been done. Obviously, you can't know you're anemic. That's an actual blood test. That's not just a feeling. But these things are extremely common for presentation of myeloma. But of course, these things are common in general. Most people in this country today that are fatigued with bone pain and have anemia don't have myeloma. And it's one of the reasons why it's often very hard to capture myeloma, because these symptoms are so general. One of the reasons why in our Empower program, which is designed to improve the short and long-term outcomes of African Americans with myeloma, who are, as I mentioned, at high risk of the disease, is to work with our primary care teams to know when to think about myeloma and what testing to do. Because the usual blood tests that we do are typically not the ones that are going to detect myeloma. As we'll show you in a moment, myeloma is a disease where a bad protein appears in the blood, and routine testing from your family doctor doesn't typically look for that protein. And so we need to understand when we need to look for that. So what is this plasma cell business? What's going on? Well, let me start simple. In our blood, we have 3 kinds of blood cells in our blood. If you think of your blood, it's liquid stuff and solid stuff. The liquid stuff we call the plasma, and the solid stuff we call cells. And you have three kinds of cells. And I assume that Dr. Rajay is sipping tea or coffee there, but who knows? Maybe there's a little bit of wine in that mug of hers. I'm teasing you, of course, before, but I sometimes say think of it like wine. We have white, we have red, and we have rosé, right? So it's not exactly the same, but we have red wine or we have red cells. What are red cells? Red cells are just little red trucks that pick up oxygen in the lungs when we breathe in, and they go deliver them to the tissues and then come back for more. I know I have personally offended every hematologist in the world right now because the blood is a lot more complicated than that, but that's essentially what red cells do. They just carry oxygen. So that's why, for example, when people are anemic or they have a low red blood cell count, they feel tired, they feel weak, they feel short of breath because they're not delivering enough oxygen to the tissues that need them. White cells, on the other hand, are much more complicated. White cells are like soldiers in an army that are designed to fight for you. Just like we have 5 branches or 5 major branches of the military, we actually have 5 kinds of white cells. And these cells are designed to protect us. And lastly, we have these little cells that are called platelets, not exactly rosé, but platelet cells. And these are little cells that help you clot. So if you cut yourself, the first thing to get on the scene is a platelet, and it plugs it up, and then it makes a phone call to recruit what we call factors. So for example, when people don't have factors, they may have diseases like hemophilia to form a much stronger blood clot. So these 3 cells, the red, the white, the rosé, or the red cells, the white cells, and the platelets, are made in the factory of our blood. The factory of our blood is called the bone marrow. And the bone marrow is really this stuff within our major bones in the body, in particular in our pelvis and in our sternum and in our spine. We have this factory growing within the bone. Within that whole big factory, you have a small amount of one kind of cell called the plasma cell, very different than the liquid plasma in the blood we talked about a couple minutes ago. But these plasma cells are very important. Now, they're typically only 1 to 2% of the factory. So imagine if this was a car factory. This is like the steering wheel, right? Really small part of the factory. I would argue a really important part of the factory, but nonetheless very small. What do plasma cells do? Well, I know Mary pretty well. And she's cool. She's amazing individual. And I'm gonna suspect that when flu season comes along, Mary, maybe because they probably mandate it in Utah, but Mary goes and gets her flu shot. What happens when Mary gets a flu shot? She gets that needle put into her arm, and it sends a message to her body to say, "Hey, body, this is what the flu looks like. You be ready if, God forbid, Mary picks up the flu." Same with Marc. I bet you Marc is fully up to date with his tetanus shots. So that if Marc is walking somewhere on a Long Island and he happens to step on a rusty nail and tetanus enters his body, how is he protected? Well, because he had his tetanus shot. And I know that Nupur is very careful and was very careful during the pandemic and other times to get her COVID vaccines and encouraged her patients to get the COVID vaccine because it affected many of us, and she knows that better than any of us. And what happens when Nupur gets the COVID shot? Well, what happens in each of these situations is that a message gets sent to your normal plasma cells. Those plasma cells respond by making what we call an antibody that protects you, or an against body antibody that protects you against the flu or tetanus or COVID. And this is a good thing. We love our plasma cells. During the pandemic, without knowing about it, you were all talking about plasma cells because we want to protect our plasma cells. They're so important. Well, myeloma is a cancer of those plasma cells. So now, instead of making good antibodies that fight off infections, they make bad antibodies that sadly start to attack the body. So now the very thing meant to protect you is the thing attacking you. And that's what makes myeloma unique compared to most cancers, is it's really a cancer of a part of the immune system. And so now these antibodies, and in medicine, we love to use words that patients don't understand. We call them immunoglobulins. It's just a fancy way of saying antibodies or these proteins that circulate in the blood. And they are now going to potentially hurt the body instead of protect the body. And if we look at these antibodies, or these immunoglobulins as we call them by different names, but they're based on these different letters that you see here and the way that they come out. They're basically shaped like a Y. Some of them have two Ys together like the IgA, or 5 of them together like the IgM. But if we look at the most common one, what's called the IgG, it's like a Y-shaped thing. And if you look at the picture that has color to it, you see that there's blue and red bits. The blue bit is called the heavy chain. The red bit is called the light chain. And when it's all together, we call that the M spike, or the monoclonal protein. Sometimes I was explaining to a medical student who was in my clinic today and said, how do I define cancer in its simplest form? 3 words: identical, uncontrolled growth. Identical, uncontrolled growth. Identical meaning it's the same thing. If it's a piece of breast tissue or lung tissue or colon tissue, it's easier to picture those cells just growing. Well, similarly here in the bone marrow, those plasma cells that normally should be 1 to 2%, as we've said, it starts to grow 10, 20, 30, 40%. And it's growing, and it's making this abnormal protein, or what we call monoclonal protein. And we either measure it by the whole intact immunoglobulin, as you see there, meaning the heavy and the light chains together, what we call the M protein, or the M spike. In the middle, you see this little spike of blue. That's literally what an M spike looks like in the lab, and then we quantify it. Or sometimes about 20% of patients actually only have the light chains, and so we measure those typically in the blood. Sometimes we may even have to measure them in the urine. Most commonly, people have IgG, but we also see IgA and IgM and D much less frequently. So that's the way we think about multiple myeloma. This may look like an intimidating chart, but let me make it simple for you. Myeloma that we're talking about tonight is in the darker blue field on the right, what we call active or true myeloma. In that case, someone has more than 10% plasma cells if we check their bone marrow. And they have what we call myeloma defining events. I haven't even defined them yet, but I'll get to them in a moment, where unfortunately there's enough of those plasma cells that it actually is starting to damage the body, typically the kidney or the bones or something like that. And we need to treat those patients. But what's fascinating, as I showed you, that's about 1.8 or so % of all cancers. It's much more common to have what we see before that, what's called MGUS, monoclonal gammopathy of undetermined significance. That's a mouthful. And basically, it just means that there are people, in fact, believe it or not, 5% of us over the age of 40, if I were to do a blood test on you today, I could find some of that monoclonal protein. It doesn't mean you have myeloma. You just have a tiny little schmutz of it. I say to some patients, it's like finding a tiny bit of dust in the corner. It doesn't mean I need to get the vacuum cleaner and clean and get rid of it, because it's so small, no one's really going to notice it. But that's what MGUS is. And we're studying this. We're doing a big study, as some of you know, in Iceland. We've screened the whole country to try and understand what's happening there a little bit better. And we've determined that about 5% of the population, maybe higher, probably 10% of the African-American population, if we look for it, have it. But the reality is the vast majority of those people, it's just a little bit of protein, and it's not going to grow, and it's not going to change their life, so we don't treat them. Think of it almost like all of us may have a tiny little spot on our skin, like a little mole, that over a long enough time might become cancerous, but it's not cancerous now and doesn't need to be touched or removed because its potential becoming cancer is so low. That's what we see with MGUS. But then we have this intermediate or middle area called smoldering multiple myeloma. And we're not going to spend a lot of time talking about smoldering tonight, although there's been a fascinating clinical trial recently that's probably changing the way we think of and treat smoldering myeloma. But in these patients, they do have more than 10% plasma cells, but they don't have any of those myeloma-defining events that historically made us say, oh, you've got active myeloma and you should be treated. So we often don't treat these patients. Obviously, there's much more to say about that, but they have a risk of going on to active myeloma of about 10% per year, as opposed to only 1% per year in the MGUS patients. And so that's why we typically aren't treating those patients. Well, what are these myeloma defining events that I commented on? Well, they spell the acronym SLIM CRAB. We used the word CRAB for years, and then we added 3 more a little over 10 years ago. And I wrote out the acronym SLIM CRAB. That was it. That's my contribution to the myeloma community. I can drop the mic and leave. That's it. But here are the things. Let's start with CRAB, because I've commented that these are the key 4 elements. That people can have a high calcium level in their blood, often because their bones are leaching out calcium. They can have renal or kidney damage. They have the anemia we talked about, or low hemoglobin or bone disease. But we've also learned that if we test for some blood tests, we know that people are very soon to have those organs damaged. And the first in the SLIM CRAB is clonal plasma cells of over 60%. So when we do that bone marrow, if it's over 60%, we know myeloma is coming very soon, and we basically treat it like real myeloma. If we have what's called the light chain ratio, remember I commented that we can measure the M spike or the light chains. If those light chains, we measure 2 types of light chains that we have in our blood. If one that's involved over the other one that's not involved, because normally we should have an even amount of both of them, but if one is so dominant over the other by 100, then that tells us that myeloma is active. Or if we do an MRI of the bone marrow itself, and a bone marrow, when we look at an MRI, should look nice and smooth, but if it looks like it's a bit patchy or focal in more than one place, then we know that's likely going to be active multiple myeloma. Now, I'm not going to go through everything on this slide. Some of these are references for you, but let me put it this way. I sometimes say myeloma is like a crime scene. One piece of evidence can't tell you the whole story. So we do like to look at the whole of someone's blood work, because we want to look for those things in the CRAB criteria. Like the first thing here is the CBC, where we look for the white, red, and the rosé. We look at the chemistry of our blood, like the calcium or the creatinine, which is a marker of kidney function. We look at some fancy protein tests, like what's called beta-2 microglobulin and LDH. And then we look at specifically that protein or those antibodies that we've talked about. And that's the test that's not typically done, as I noted, by primary care or by your family doctor, because we use it in special cases. But this is the key test for myeloma patients, because we want to check, do they have an M spike? Do they have light chains? So we do the serum protein electrophoresis, and we do what's called the serum-free light chain assay. And then sometimes we do have to check it in the urine as well. At baseline, we always check it. Typically, if we can measure it in other ways in the blood, it's easier to collect blood than urine, to be honest. It's no fun for those of you who've had to collect 24-hour urine tests on a regular basis. And we hope to be able to do, even less of that in the near future. And then we image myeloma. That's part of the crime scene. So the blood tells you one thing, and now x-rays tell you another thing. In the old days, we used to do a skeletal survey, or channeling my inner Canada for a minute or two. We used to call it the skeletal survey. Sounds very British, yes. But now we've learned that that's not a really good test, because there has to be a lot of damage to the bone for it to appear on a regular x-ray. We've learned that it's better to use either a CT or an MRI modality. So whether that's with a whole body CT or a PET CT, your doctor may do it in different ways. But again, it's looking for thinning of the bone or cracks in the bone or holes in the bone that speak to the fact that those plasma cells and the protein that they make like to attack the bone. But we don't only do that. We have to do the beloved bone marrow test, right? Again, this is part of the crime scene. Part of it's blood, maybe urine, x-rays. Now we do the bone marrow test, because the bone marrow is the factory of the blood, as I mentioned. And so this is really where the plasma cells live. So it does unfortunately mean sticking a needle in there, and we take out a bit of fluid, and sometimes we core out a piece of the bone, what's called the aspirate and the biopsy. And there can be a lot of complexity here, and it's a whole talk in and of itself. But I do want to say that, as I'm going to show you in a moment, staging in myeloma is really complicated, and we typically don't get too excited about staging, but we get a little bit more excited about the genetics that we find in the bone marrow. Now, these aren't the genetics you pass on to your children. These are the genes of the cancer cells that live within your bone marrow. And we look at their genes because we figure these cells have become cancerous because there's been mutations or something that's gone on wrong with them. And we've learned over the years that there are certain genetic changes that either point to someone having so-called standard risk myeloma versus high risk myeloma. And let me simplify it. 25% of patients we put into the high-risk bucket, and about 75% of patients are standard risk bucket. And there's some differences because it does affect prognosis. Just being open and transparent, we've made massive improvements in survival in myeloma. When I started in myeloma, and some of our speakers here may still have been in utero, but back when I started in myeloma, 25 years ago, most of the patients we saw lived 1 or 2 years. Now, most of our patients are going to live more than a decade. But we have learned that one of the things that can be challenging is dealing with high-risk myeloma, where the myeloma tends to be more aggressive. It tends to come back more quickly because we haven't yet, as we're going to hear from our speakers, fully cured myeloma. We can often control it for a long period of time. And so we look for certain things that indicate high-risk features. Right now, we look for things like, as you can see here under these fancy words, deletions, translocations, and gain, particularly this 1Q gain, those 3 translocations in the middle, and that 17P deletion as you see there. Now we're about to revise this and hopefully make it a little bit more simple and straightforward for us all. But the reality is, at the end of the day, knowing that you have either standard risk or high-risk myeloma may influence some of the treatment that's given. Because over the years, we have tried all these different staging systems. We used to have something called the ISS, and then we revised it and called it the RISS. Then we revised it again and called it the R2 ISS. And I'm not making light of these different scales, but we don't want you to think of myeloma like you might think of solid tumor, where the difference between stage 1 and stage 4 is vastly different. We don't have that same division in myeloma. Remember, myeloma is not really ever metastatic because it is in the blood to begin with, so it's circulating to begin with. But we do use some of these scores to help us. But in the future, it's going to be, I think, a little bit more simplified. All right, in my last few minutes, I'm just going to talk about generally how we think of treatment. And then, as I say, the appetizer will be over, and you'll get the main dish, starting with Dr. Braunstein next. When we think of someone diagnosed with myeloma, active myeloma that we're going to treat, we typically divide them, as I noted, into 2 buckets. Is someone going to have a stem cell transplant or not? Nowadays, almost whether or not they're going to go to transplant, the treatment at the top in blue here is actually quite similar. I would argue that for the majority of our patients, we're now using a quadruplet, as we call it, or a 4-drug combination. If we were doing this community workshop 2 years ago or 3 years ago, we might have said, well, really, 3 drugs is the way to go, or maybe 4 drugs for transplant eligible and only 3 drugs for transplant ineligible. But Dr. Braunstein is going to demonstrate to us now we have evidence and a recent FDA approval of giving 4 drugs even in transplant ineligible patients. So I'm going to argue that starting now, most of our patients get 4 drugs. And part of that is the concept that when we use different combinations together, we have a better chance of controlling myeloma. For those of you who know the field, how did we overcome HIV? Mostly, not because of one magic drug, but because of the right combination. And so here we use a combination of drugs, and then patients get a transplant. Dr. Rajay will talk to us about what a transplant is all about. And then people go on to so-called maintenance therapy. And the idea there is, let's get you into a remission. Remember, remission isn't cure. Remission just means that we get your disease down to a certain level, but then we want to maintain it. And we've learned over the years that certain maintenance strategies can be very helpful. All the while, as Mary is going to teach us, we want to support the rest of the body, right? We're not just treating myeloma, as I said, we treat people. So we want that supportive care and live well. Sadly, the reality is, for the vast majority of patients with myeloma, their disease will come back at some point. Thankfully, for most patients, it takes several years before it comes back now with these newer therapies. But sadly, for some, it may come back even within that first year. And we treat it, and it goes into remission again. And then sadly, it typically comes back in less amount of time. And so, as you can see here, what I've written is LOT, or line of therapy. We get a second line of therapy, then a third, then a fourth, and a fifth. And with each line of therapy, the myeloma sadly comes back a little bit more aggressively and a little bit more difficult to control. Now, I purposely will not walk through all of these over these next 2 slides, but I loved creating this table because patients always ask for it, so feel free to screenshot it. We also have it at the myeloma.org website, where we update this on a regular basis. But this is just a reminder of all the drugs that we have in myeloma that you're going to be hearing about over the next little while. And obviously, as I mentioned, I'm not going to go through all of them, but I've tried to summarize them here into what class they are, what their names are. I'm sorry that almost every drug has two names, the so-called trade name and the generic name. We're trained in medicine to try and always talk about the generic name, but then sometimes we have to use the trade name because that's what the short form is. And so I know when Marc speaks in a few minutes, it's hard to not use these acronyms that scare people off, but these are the combinations that we have. So we have very important different drugs here, the immunomodulatory drugs, the proteasome inhibitors, and the monoclonal antibodies, along with so-called standard chemotherapies and then steroids. And we'll talk a bit about steroids today. There's always a question about steroids. I had the privilege of just recently writing an editorial in our journal called Blood, called Down with Dex, that I wrote with our nurse practitioner. Mary, you'd love her. Susie is fantastic, who I work with in my clinic. And we talked about how we really are probably using too much dexamethasone in patients, and we can back down on it. We have a new class of drugs called XPO1 inhibitors. And then some of the things that we know Dr. Rajay in particular will be speaking to us in the relapse setting, we have these incredible new classes of drugs with BCMA targeted, what we call antibody drug conjugates, CAR T-cell therapy, and bispecific antibodies. And it's just hard sometimes even to believe how many drugs we already have approved. And then what I've listed here in the pipeline is a whole series of other drugs that are coming. And obviously we don't have time to get into all of that tonight, but it's exciting to know that's coming in the future. Dr. Rajay will also comment in a few minutes about MRD, or minimal residual disease. As I noted, when people get into remission, that doesn't mean cure. But whatever their starting M spike level or light chain level was, we want to see that come down. We consider it response when it's cut in half. We call that partial response. If it goes down by 90%, it's a very good partial response. If it goes down by 100%, it's called a complete response. And we have some writers there to explain that a little bit more. But recently, we've been very excited about this concept of MRD, or minimal residual disease, where we do a bone marrow test typically, although we're hoping to do it more in the blood in the future, where we look, not only do we not find big volumes of plasma cells, we look for one plasma cell in a million or even 10 million. To see if there are any plasma cells left. Because when we get the disease that low, we know that it's likely to stay in remission for a longer period of time. Well, as we mentioned, we're not going to focus on relapse tonight, but the disease typically does come back. And typically we start to see changes in the lab work before a patient feels it, which is one of the reasons why we need to monitor this disease and keep an eye on it as we go forward. All right, before I close off and turn it over to you, Marc, in just a couple of minutes, I just want to remind people that myeloma is a war between us and the plasma cell. I'd like to say that more often than not, we win the war, but sometimes myeloma becomes very resistant. And one of the ways we attack myeloma is we've learned there are things on the inside and there are things on the outside of the cell that we can use, if you will, as a target. And I know a lot of these look like license plates. I'm sorry, I didn't name them. Don't blame me. But there are things on the outside of myeloma cells that you're going to hear about tonight. Something called CD38 that we use antibodies to attack, or something called BCMA, which is what we use when we're going to hear about CAR T-cell therapy, some of these bispecifics. And then there are newer targets, something called GPRC5D, something called FCRH5. And the reality is we've developed drugs to attack the myeloma at these different things. We have something called an antibody drug conjugate. We have a drug that was approved, Blenrep or belantamab. It was removed for the market. We all believe it'll quite likely come back this year. It hooks onto the myeloma cell, and it has a backpack, and in that backpack is a toxin that it drops into the cell, and that can help damage the cell. We have something called bispecific antibodies. So you have cells in your body that are like soldiers. They're called T cells. And what we do with bispecific antibodies is we give you a drug. It's called bispecific. It has two arms. One arm grabs onto the myeloma. The other arm grabs onto a local T cell and engages that T cell or awakens that T cell to destroy the myeloma. I know it sounds like a Star Trek movie, but it really is what we can do. And we have now 3 approved bispecific antibodies. We have CAR T cell therapy, which arguably, and Dr. Rajay has led the world in many respects in this field, in the work that she's done, has revolutionized our treatment. It's a little bit like what I described with the bispecific antibodies, but here we actually take T cells out of you and we train them to fight your myeloma. It's called CAR because it stands for chimeric antigen receptor. And the key thing is we put a receptor on the outside of these T cells that's like a homing mechanism to detect your myeloma, and then we give them back to you, and it goes and hunts your myeloma. So we collect T cells, like those of you who have been through a stem cell transplant, you know what it's like to have cells collected, and then we manufacture these T cells and give them back to you several weeks later. So I'll come to a close now and to say it's amazing to see the evolution. This may be my favorite slide that I have the privilege of updating. It seems almost every month I have to update it with newer drugs that are being added all the time. The drugs that we have now up above and the drugs below that we're working on. It really is amazing compared to when Dr. Rajay and I started in myeloma and we had 1 or 2 drugs. Look what we have now. I mean, this is like a buffet, and we're very grateful that we have this opportunity to share this with our patients. I'll close by saying that one of the things we believe strongly at the IMF is that you have the privilege and the opportunity to get a second, or I prefer the words expert opinion. Second opinion sometimes makes it sound like the first one didn't go right. And we do think that myeloma is a specialized field. We have a huge network of myeloma doctors across the country. We're happy to help you find that so that you can talk to them about some of the things that you're going to hear tonight. And of course, we have a huge amount of resources at myeloma.org. And I have the privilege of overseeing this aspect of our work where we have so many different publications that we're happy to share with you at any point. And of course, engage with you on social media. You can follow us on any of these channels, and there'll be so much information for you and opportunity to ask questions. And thank you, by the way, for the several of you, over a dozen already, questions that have come in. Well, with this, I'm going to stop. We're right on time, Marc, hard to believe. I will turn it to you, my friend, to help us understand a little bit more of how we manage patients that are not going to transplant. I shall turn it to you. Thank you.
All right. Thank you, Dr. Cho. That is a hard appetizer to follow, but you've had your red, white, and rosé wine, and I guess I am your pasta course. So thank you, everybody, for joining. I'm going to be talking about managing newly diagnosed myeloma not going to transplant. And we say not, it could be either that it's deferred or someone is truly not eligible ever to go forward to stem cell transplant. Right? So it's really a privilege to be here tonight to talk to you with the International Myeloma Foundation. And our objectives, again, are to focus on individuals who are going to get treatment for newly diagnosed myeloma, but not necessarily go forward after that initial treatment to an autologous stem cell transplant for consolidation of their disease. So we'll discuss some of the evolving treatment strategies and understand the different combinations and really highlight the importance of individualizing treatment for the patient that we have in front of us. So I think everybody here is familiar with the myeloma journey. Sometimes I explain it to patients as the marathon because it's more of a marathon than a sprint. There's this asymptomatic phase of MGUS or smoldering myeloma, and eventually someone progresses to those slim crab features where they need treatment to prevent further organ damage. And so the monoclonal protein, or M-spike, may be high initially, and we want to bring that down as it correlates with response to treatment and fewer of those nasty plasma cells in the bone marrow. And so what are our goals in terms of first-line treatment? Well, number one, we want to identify this symptomatic phase of myeloma as soon as possible to limit the amount of organ damage that results from those plasma cells dividing in the bone marrow. And then we want to delay progression. We want to extend this first remission, which is typically one of the longest remissions, as long as possible. And overall, increase survival, and most importantly, improve quality of life, which may mean different things to different individuals. But that's really an important goal as we talk about different treatment options. it's really gratifying to see how much we've pushed the bar further in terms of increasing survival. In fact, the 5-year overall survival is close to 61%. Obviously, there's still room for improvement, but you can see in the past 20 years or so, there's been almost an exponential improvement in survival, thanks to a wealth of physicians and scientists who have contributed to new developments as we better understand the field of myeloma, its biology, and how to better treat it and harness that understanding for new treatments. And examples of that include new agents that were developed, such as lenalidomide, which we're going to talk about, or bortezomib, which target some of the inner workings of those plasma cells, or monoclonal antibodies, which I'm going to really focus on and explain to you further in the next slide. And Joe spoke about CAR T cells and bispecific antibodies. All these things continue to improve the survival of myeloma patients, and it's really an exciting time to be in the field. And when you look at the kind of timeline of the development of new therapies, what you see is there's a lot of developments in the past 10 to 20 years, which is very exciting. And that includes what I mentioned before, classes of drugs called proteasome inhibitors or PIs or immunomodulators or IMiDs, and those are like your Velcade or bortezomib or lenalidomide or Revlimid, and monoclonal antibodies, which I'm really going to focus on in terms of their use in first-line therapy now. And we're really seeing this revolution in use of immunotherapies, essentially harnessing the immune system to attack the myeloma. And that more recently includes these therapies that redirect T cells to attack the myeloma. And that can be something called bispecific antibodies that activate T cells, or CAR T cells, which are modified T cells that act against the myeloma plasma cells. So in this kind of simplified slide, before we get into the woods, into the weeds about the details of these different regimens we have available to us now for patients not intended for stem cell transplant, I want to say that there are different ways to get to remission, which again is one of our first goals when we see a newly diagnosed multiple myeloma patient. There are more aggressive ways, there are less aggressive ways. There are patients who need a more aggressive approach because they have a higher bulk of disease or more end organ damage. And there are then those patients who maybe need a less aggressive approach or are not fit for a more aggressive approach. So this is part of our task, working with patient and their family to decide what is the best regimen for them that will bring them to remission, but also be best tolerated. And so in choosing the best treatment for you, the things that I think about are the individual before me, what's their overall fitness, and we even have calculators specific to myeloma that help us decide on a patient's fitness. What are their other medical conditions or comorbidities? Do they have kidney damage that might be due to the myeloma or from other medical conditions? Are they fit for transplant? And that can be a complex assessment that's best done by someone who's familiar with stem cell transplant, but often takes into account these other features. Do they have good caregiver support? Do they need more caregiver support? Because that will help them as they go through their treatment journey. And what are their individual preferences? Are there someone who's working in a busy job and doesn't want to come for frequent infusions? Or are they someone who lives far from the treatment center? Or none of those factors? And then the disease-specific factors. What is the burden of their disease? What is the extent of their organ dysfunction? Like Dr. Joe said, the stage doesn't exactly function as a means of deciding on the treatment course, but it helps us give the patient a sense of the prognosis. And then there are some emergency situations. For example, somebody may present with a fracture in their spine impinging on their spinal cord, and that might require emergent treatment such as radiation just to heal that before we start the definitive therapy. And then, of course, deciding ultimately on the treatment plan. So, what combination of those therapies are we going to use? Do they need additional supportive medications to help strengthen their bones? Call those drugs bisphosphonates, for example. What should we give the individual to prevent infections? Because myeloma is a disease of the immune system, and the treatments often lead to further suppression of the immune system. And then there's always the importance of not forgetting everything else about your health. So diet, exercise, and emotional support is important as well. All right, so this is just the general algorithm of how I approach a newly diagnosed myeloma patient. I kind of make those various assessments about the patient, their disease, their preferences, and so forth. And then we almost always use a multi-drug approach to target the different weaknesses of those myeloma plasma cells. Some patients are assessed as being eligible for transplant, and others are not, or may choose to defer transplant, and that's okay, depending on how they respond to their initial treatment. And then the next phase from there, if they do not choose to pursue transplant or they're not eligible, is some form of consolidation and maintenance to keep the myeloma in remission. So before we get into the details about different types of treatment for myeloma patients who are not eligible for transplant, I just think it's important to understand, as Dr. Joe explained before, about what an antibody is. So again, multiple myeloma is a cancer of plasma cells that often occurs solely in the bone marrow where they live, and they produce these different types of monoclonal proteins, and we call those immunoglobulins. And so we can harness this information to go back and create our own antibodies now in a lab that are used therapeutically to go back and target the myeloma. So an antibody has this smaller part called a light chain because it's lighter, and a bigger part called a heavy chain because it's heavier. And this part in yellow of the antibody, or the monoclonal antibody, can be adjusted so that it targets a specific antigen or a specific target, and that can be a target on plasma cells that we can use therapeutically to destroy them. Before I talk about how we're using these monoclonal antibodies for treatment, in the era before these therapies with monoclonal antibodies became available, the standard of care was a combination of 3 drugs, a proteasome inhibitor called bortezomib or Velcade, or V for short, an immunomodulator called lenalidomide or Revlimid, or R for short, and the small d dexamethasone. And they did a study to see if adding bortezomib or Velcade to lenalidomide and dexamethasone in patients who are not going to go for stem cell transplant was better using 3 drugs compared to 2 drugs. So when we added 3 compared to 2, what you can see in this result graph, which is called the Kaplan-Meier curve, it looks complicated, but basically when we cure myeloma, we'll see a line that's flat at the top because 100% of patients are going to survive. But what you can see here is that the red bar, which was the 3 drugs, did better in terms of incremental improvements in survival compared to the blue bar with only 2 agents. So 3 was better than 2. And in the studies I'm going to show you, we looked at whether 4 was better than 3 for patients who are not eligible for transplant when we add the 4th drug, which is the monoclonal antibodies. So we have various monoclonal antibodies at our disposal now to treat multiple myeloma. Some are bispecific antibodies, which also activate T cells against the myeloma. But the 2 main monoclonal antibodies I want to discuss today, which many of you have already heard of or may have received, one is called daratumumab and one is called isatuximab. So what are the differences between these 2 antibody therapies? Well, they both target something on the surface of the myeloma plasma cell called CD38. So that is a marker that is very specific for myeloma plasma cells. Both daratumumab and isatuximab are both those antibodies that target slightly different parts of the CD38 molecule. And when they bind to it, that leads ultimately to the myeloma plasma cell destruction. There are some nuances here. Daratumumab can be given both IV and as a subcutaneous injection. Right now, isatuximab is only available as an IV, but they're working on an injector that's under the skin. And both have been studied in the newly diagnosed setting, as well as the relapse setting in patients who have received prior treatment. Their side effects are very similar. Both can lead to reduction of the normal blood counts and increase the risk for infection. So this slide is a little bit of a masterclass in how to make a slide that's way too busy, but I will just give you this bird's eye view of all the studies in one big slide in a very complicated way that I would present to my colleagues in a grand rounds talk of the studies that have looked at 4 drugs versus 3 drugs for the most part here in both transplant eligible patients, and those are the two studies on the left, which I believe Dr. Raju is going to speak about, and the four studies on the right, which have looked at transplant ineligible patients or those not intended for stem cell transplant. And from a very simple bird's eye view, I can say that when they looked at various endpoints, whether it was progression-free survival, how much time the patient was in remission until they progressed, or whether they achieved minimal residual disease or MRD, which is as deep a remission as we can get, all these studies showed that when you add the monoclonal antibody, whether it was daratumumab or isatuximab to our conventional 3-drug regimen, all of them showed improvements in outcomes. And I'm going to break some of this down for you very quickly with my time remaining. So the first study I want to show you about, I'm going to show you the actual details of the study. It's called the MAIA study. They first looked at whether 3 drugs using a monoclonal antibody called daratumumab was better than just the historical standard of lenalidomide and dexamethasone alone. And when they added daratumumab to this 2-drug regimen, they showed that there was an improvement in the time to progression as well as the overall survival. And so this sort of became a preferred regimen for patients who are not intended for transplant. So lo and behold, then we asked the question, well, if 3 drugs using the monoclonal antibody daratumumab are effective, what if we just gave the 4-drug regimen to patients who are not intended for transplant? Because this was already being looked at in patients who were going for stem cell transplant after this initial therapy. And there's a regimen in this study. It was a study called the IMRA study, and they used isatuximab instead of daratumumab. But again, it's very similar in terms of how it targets the CD38 molecule on plasma cells. And they gave the isatuximab with bortezomib, lenalidomide, and dexamethasone, or ISA-VRD, and they compared it to a 3-drug regimen of VRD alone. And eventually, after the initial treatment, so patients were randomized in this study to the 4-drug regimen or the 3-drug regimen, and eventually they stopped the bortezomib to avoid peripheral neuropathy, which is a complication of bortezomib. And I should say that before I show you the results, this study ultimately led to approval from the FDA of this 4-drug regimen for people who were not fit enough for stem cell transplant, but still could receive this 4-drug regimen with isatuximab, the monoclonal antibody. So very quickly, this was the study population. There were twice as many patients in the study who got the 4-drug regimen compared to the 3-drug. And you can see the age distribution was generally above 65. And these were patients who in this study were considered not to be eligible for transplant, although I should mention age is not the only factor when it comes to deciding whether someone can move forward to a stem cell transplant. And here's the impressive outcomes. They looked at both the rates of absence of any residual disease or absence of MRD or MRD negativity, and those were higher when they added isatuximab to the 3-drug regimen. And again, this progression-free survival, how long did it take until patients progressed? And that was longer in the patients who got the isatuximab. So this was what we would call a positive study and ultimately led to FDA approval. Now, of course, we can't look at the benefit alone. We have to look at the side effects. And, this is the actual table from the paper, but I'll break it down for you that essentially there are higher rates of reduction in the blood count, something that oncologists are very comfortable managing, when they added the 4 drugs versus the 3 drugs. And this is not surprising. It's common to have reduction in some of the bone marrow function when we're treating multiple myeloma with more agents. And there were slightly more rates of infection. In the study, they break these down by grade, and grade 3 or higher side effects tend to be more worrisome, but there were slightly more infections when they added the monoclonal antibody. So that led to the FDA approval, and that regimen is now available for patients who are not fit for stem cell transplant. One last study I want to present to you. This was a study that was recently published called the Cepheus study. And very similar to the prior study I showed you, they looked at adding daratumumab. In this case, they used daratumumab instead of isatuximab with that 3-drug regimen and compared it to the 3-drug regimen without the antibody. In this case, patients are randomized. Half got the 4-drug regimen, half got the 3. And the difference in this study in a kind of nuanced way is they allowed patients who wanted to defer transplant. They may have been eligible, but they wanted to defer transplant or they were ineligible. So it was a little bit more of a mixed group of patients in terms of their transplant eligibility. And in that sense, the average age of patients in this study were just a little bit younger than the other study. And again, what we see as a common theme is when we add the antibody to that 3-drug regimen, the outcomes were improved. Again, you see better rates of absence of MRD, and you see a longer time till progression. And again, when you look at side effects, again, we don't have to go into the details here, but there are slightly higher rates of infection and a reduction in normal blood counts when you add a monoclonal antibody in this. And finally, for my last slide, just to give you a taste of the future of how they're looking at different antibodies in clinical trials, we're using various antibodies that have been approved in later lines of therapy now in the first-line setting. For example, Dr. Joe mentioned about belantamab, an antibody that targets BCMA that has some luggage with it to further destroy the plasma cells, and they're looking at that in first-line therapy. Or CAR T cells. These are cells that have been reprogrammed to attack the myeloma, similar to the way antibodies do. And they're looking at those in the first line as well. Or bispecific antibodies like teclistamab or talquetamab. There's a study looking at those T-cell activating antibodies in combination therapies in the first line, again, for patients who are not intended to go for stem cell transplant. So with my very last slide, I'll just say, you know, we're really witnessing an immunotherapy revolution, and it's very exciting at this time in the field. Adding either daratumumab or isatuximab, both of which target CD38, to other drugs like bortezomib, lenalidomide, dexamethasone clearly improves our outcomes in newly diagnosed patients with or without intention for stem cell transplant afterwards. Isatuximab BRD is now approved for transplant ineligible patients, and I think we'll see the same for daratumumab BRD within this year. And I'll just say that while stem cell transplant remains the standard of care for those patients who are fit enough for it, no study has really compared whether if you give somebody a quadruplet, a 4-drug regimen, and then randomize them to transplant or no transplant. So we don't know the answer to whether you still need a transplant if you've gotten a 4-drug regimen. But clearly, the 4-drug regimens do better than the 3-drug regimens, whether you're eligible or not for a stem cell transplant. So regardless of the goal, regardless of the regimen rather, the goals really remain the same. Prolong survival, prevent organ damage, and improve quality of life. And with that, I'll just thank my team and that I have the pleasure of working with, and of course, our patients and their caregivers. Thank you.
Wow. Thank you so much, Marc. Great lecture, and you stuck to time. I think I'm going to bring all of our faculty together here for a Q&A. A lot of questions have come directly to me online as well as through the chat. So let's spend a little bit of time going through some of these questions. Really appreciated your lecture, Marc, how clear you made it, the analogies that you used. This was great, and we'll dive in. And so I'll call on each of our speakers at different points. Even if they haven't spoken yet, we'll get some of their questions ready up now to get rolling. So the first question is, will we also touch on a smoldering myeloma? I assume that the author here was smoldering myeloma. I'll take this quickly. There's so much that we could say about smoldering myeloma, but let me use this analogy. Sometimes I say to patients, smoldering myeloma is like someone is running towards a cliff. And maybe it's because I like running. I suspect Marc is probably running faster than I am anyway. But if Marc is closer to the cliff and he sees me heading towards the cliff, hopefully he'll stop me from falling off the cliff and obviously causing a lot of damage. We used to define myeloma as running over the cliff. And you had CRAB criteria. You had to have organ damage, the calcium, the renal, the anemia, the bone disease that we talked about before. But then we drew a line, let's say 50 feet short of the cliff, and said, you know, if you're this close to the edge, slim CRAB, then we know you're so close to getting active myeloma. But then there's still this space on the other side of the 50-foot mark where people are getting very close. And historically, we even divided that into so-called standard risk and high risk smoldering myeloma. But in general, unless it was a clinical trial, we didn't treat it. More recently, we had a very important trial. For those of you who watched the patient-friendly overview of ASH that I did in January, we talked about the Aquila trial, which basically compared giving nothing, the usual close monitoring of patients with smoldering myeloma, versus a 3-year course or a planned 3-year course of just single agent daratumumab, Darzalex, that Dr. Braunstein just shared with us. And it really showed an impressive difference in terms of the time to developing myeloma and even an overall survival advantage. So it's still a little bit early, and I think we're still processing this and getting some more information in, but it does provide yet another option for patients, a very legitimate option, who may not wish to go right into the quadruplet therapy of active myeloma, who may not want to just wait and watch, as it were, but maybe if they have high-risk smoldering myeloma, be treated. And we're going to discuss that a lot more at several community workshops in the future. Here's a question for you, Mary, if I may. What lifestyle choices contribute to a longer remission?
Love this question. There is nothing very specific I can say here, but I do think that like a healthy lifestyle in general. So we know from some clinical trials that a diet that is full of fiber and whole foods is better for our immune system, and that can certainly help. Keeping free from infection can also help. Reducing stress also helps. So when you have active myeloma and you're on a treatment, the more you can do to kind of optimize the rest of your life in terms of good sleep, regular exercise, healthy diet, that all contributes to better tolerance of medications, perhaps less infections and less complications.
Fantastic. I love your answers always to these. In fact, there's another question that came in saying, is there research being done on, ketogenic or other diets to help us know if they can influence outcomes? And I will comment that, Dr. Urvi Shah, who's a well-known myeloma doctor, Memorial Sloan Kettering, is doing what's called the Nutrivention study. We're actually looking to see if a dietary intervention could potentially slow the progression of MGUS or smoldering myeloma towards active myeloma. And of course, we would love to be able to do it in a way. Our patients want something that they can control. And so I'm very glad, Mary, that you point out that there are things that we know that absolutely can make a difference. As for the dietary intervention, we're still learning if it's specific to myeloma, but whether it's going to be specifically helping myeloma or not, we know that generally healthy lifestyle, as you said, makes it easier for people to tolerate treatment, allows people to have a greater quality of life through it. So don't feel that you are at the hands of the quadruplet therapies that Dr. Braunstein just explained. It's much more than that. And I'm going to add in, we know that actually when patients are part of a support group and they have a supportive environment around them, it actually does impact their outcome, because I think they're, even just by being on this webinar tonight, or whenever it is that you're watching it, is empowering you to, I believe, a longer remission into a better life. Dr. Rajay, maybe I'll ask you this question, a little bit in the weeds, but an important one. We know now that a lot of our patients who have historically received Revlimid may now receive it as a generic form of Revlimid. And we're not going to get into the politics of generics and all that sort of thing, but have you seen a difference in your practice between people who are on the generic versus the Revlimid itself? Are they equivalent? Is it okay for people to take either or?
Yeah, no, great question, Joe. And I think most patients should be reassured. No big difference between the generic Revlimid and lenalidomide, and whatever is available and accessible is what patients should be on. I haven't seen any differences.
Yeah, I would agree with that. I think
efficacy
especially
or toxicity, right? Both
right.
Efficacy and toxicity.
And I would 100% agree with that, especially with the generics that we now have available in the U.S. We had a question a few years ago when people could obtain generics from, other international places where there may not have been the same quality assurance. But I think here we really haven't seen a difference in either efficacy or toxicity. Marc, maybe I can ask you this one. Is there a connection to having a family history with chronic leukemia? Or do we know of that kind? I know I talked a little bit about family history of myeloma, but just to answer this question in particular.
So to answer the question, I'm not aware of any particular connection. It is possible for someone to have common exposures. For example, in my area, we have people who are 9/11 first responders who are prone to MGUS and multiple myeloma, among other hematologic cancers like chronic leukemia. But I'm not aware of a connection that one leads to the risk of the other.
Yeah, I think that's the correct way to do it. I would add to that we know that somewhere around 5 to 8% of myeloma patients over the course of their myeloma journey will have a second cancer. We don't always understand the full mechanism. I try to simplify it for patients, say we think it's generally speaking one of three things. One, someone's inherent genetics put them at risk of one cancer, and so they may be able to develop another. We just see that, not just with myeloma, but with other cancers. Number two, there may have been a treatment that someone received that could potentially increase their risk of another cancer. We've seen this with transplant. We've seen this with maintenance Revlimid. We do think that that risk is probably not as large as the risk of the active myeloma they have, right? You've got a cancer in front of you. Let's treat it the best way possible, as opposed to just worrying about a potential cancer that may come. But of course, we have to keep those in balance. And then three, and not to be lighthearted about it, but I sometimes call it the incidental loma, is a function of the fact that cancer patients, in particular myeloma patients, are watched very closely. And so they might detect something that someone in the general population might not have. So those are the three mechanisms of it. And that's why it reminds us that even though you're a myeloma patient and obviously very taken with your myeloma treatment, please keep getting your breast cancer, your colon cancer screening. Please follow up with your family doctor for your diabetes, for your high blood pressure, all these other things that we know are important to our health in general. So, Dr. Raj, I'm going to ask you this question. Someone is asking about the fact that they got DVRD induction, so one of the 4 drug combinations I know you're going to be talking about in a minute. They had their stem cells harvested, but they were in such a deep remission, they decided not to go on to a transplant. Is this being studied? Are there studies that evaluate this kind of person? I know Dr. Braunstein already in some ways talked about people who are deferring transplant, but maybe you can just talk about that for a minute or two.
Sure, and we'll talk more about it after the break as well, Joe. But that's the reason why we think that looking at MRD or minimal residual disease negativity should be the goal of whatever 4 drug regimens are. And I will show you some data in the study where we did transplant versus those who chose to defer a transplant. And I always say, transplant is a choice. Dr. Braunstein very nicely pointed out that all the quadruplets have just incorporated transplant into their treatment regimen as part of their care. And we could, so we don't know whether or not a transplant is absolutely essential. But when I show you the data, if you've achieved MRD negativity and have chosen not to go forward with the transplant, the outcomes of patients are quite similar. So in a subset of patients, I think we would suggest transplant should be considered for sure. But in others, if you make a choice of not wanting to go ahead with the transplant, it should be totally fine. And I always tell all my patients, transplant is a discussion and it is ultimately a choice.
Excellent. And there's a couple of questions here that are about the difference between allo and auto transplant. I'll let you answer that when you come to give your talk, and so we can get into that. And I know you're going to talk a little bit more about MRD and the way we do it. But I do find it fascinating that there are a lot of questions here about what is the algorithm to cure. So we'll leave you to comment on that a little bit, because I put 10 myeloma doctors in a room and I have 20 ways to define cure. But we know all at least can agree that MRD is a path to getting there. And for the person who asked the question about how we can measure MRD, I mean, we are typically now doing it through bone marrows, because that's where, if you will, the headquarters of myeloma is. But a lot of us, including the lab that I work with, we are looking at ways to try and do it through the blood. I would love to find a way to order less bone marrows on my patient. Everybody would rather have a blood test than have a needle stuck in their backside. I get that. But we're not quite there yet. Even with mass spectrometry and other means, we're getting closer, but I don't think we're there just yet. Someone asks, what if you have non-secretory myeloma? What does that mean? So when I showed you the pictures of the plasma cells making antibodies, that's what plasma cells are designed to do. There is actually a form of myeloma. We don't see it very often anymore because our tests are so very carefully done now, but probably around 1% of patients still have what we call non-secretory myeloma, or this can happen later in someone's myeloma, where there actually is no monoclonal protein released by the plasma cells, whether it's the M spike or the light chains that we described before. That's a challenging situation because it may be difficult to measure the myeloma that way. Now, as I said before, remember, myeloma is a crime scene, maybe through imaging, through bone marrow. So we have to use other modalities to monitor the myeloma. So it can make it a more complicated. And sometimes, unfortunately, it might mean that someone may not be eligible for a clinical trial, because many clinical trials do mandate that we have a more easily measurable phenomenon. That being said, I think we are seeing more trials that are capturing it through so-called extramedullary disease, which was another question here asking about extramedullary disease. Extramedullary, medulla is just an old word for bone marrow. Think of it that way, where when someone has disease that lives outside the bone marrow, so sometimes we can find disease, especially with our new, more sensitive blood imaging tests like PET scans, we can see myeloma outside of the bone marrow. Typically means that the myeloma is a little bit more aggressive, not always so, but generally speaking, and so sometimes we can use the imaging to do that. So great question here about when to discontinue maintenance therapy, and I'm going to save that for later for you, Dr. Rajay, as well as the difference between CAR T and bispecifics. So I think at this point, we've covered a fair amount of the slides. There are some other ones that are really very relevant to the second half of the show. So we are going to take a 10-minute break in just a minute, but I want to tantalize you with what's to come in 10 minutes from now, when Dr. Rajay will talk to us about patients who have newly diagnosed myeloma that are transplant eligible. And then Mary's going to tell us how to live la vida loca. Like, she's going to tell us about living our best life with multiple myeloma. But at this point, it's 1:15. Let's take a 10-minute break, and we will be back in 10 minutes. Thanks, everybody. got a series of questions that came in separately on hypothyroidism with lanolin. Is that something you've Welcome back, everybody. I hope you had a nice, quick but effective break. We're very much looking forward to our final two lectures and more time for Q&A. Thank you for sending so many questions in. Feel free to use the Q&A button there that you can enter questions in live, but it's now my privilege to hand things over to Dr. Nupur Raje from Mass General, who is going to talk to us about treating patients who are planned to go to autologous stem cell transplant. So I'll turn to you, Nupur, and then I'll quickly introduce Mary after you're done.
Perfect. No, thank you. Thanks so much for having me on this. This is always a fun conversation to have, and it's amazing how patients are so involved and wanting to learn about the disease. So as you pointed out, Joe, I'm going to be talking about the newly diagnosed patient who is potentially being considered for a transplant. And really the stage has been set by both you and Marc. You gave a really nice overview of the disease itself, and Marc did an incredible job going over so many different treatments which are available. So my job is a little bit easier because of that. But just to recap a few things, myeloma, as you so nicely showed us, Joe, it is a disease with expansion of these abnormal plasma cells, and it's not that uncommon. There are quite a few patients with myeloma, and more importantly, because of all of the advances we've made, there are a lot of people living with myeloma. So this whole notion of living well with myeloma is something which I take to heart, and Mary is going to be talking to us later on about what we can do to continue to live our best lives with myeloma. So with that, just to recap the clinical presentation, Joe, you talked about bone disease. A lot of our patients do present with bone disease either on imaging or present with a bone-related event such as a fracture. You have increased protein in the blood, which is oftentimes how the disease is diagnosed. You can have unexplained anemia. You can have a high calcium level because of the bone disease, and you can end up with problems such as kidney problems. And that's why I think the 10-minute break was perfect, so that all of you could get your hydration in. So with that, I think when you think about the treatment of myeloma, I think the question we all have to ask ourselves is, what should be the goal of treatment of myeloma? And there's a lot of conversation about minimal residual disease, and should that be the goal of getting to MRD negativity? And I'm going to talk to you a little bit about this because of all of the different treatments that we have, and just to give you a sense of where we are with myeloma. If you look up top at the number, these are plasma cells which are highlighted on your left panel. When you're diagnosed with myeloma, you have lots and lots of plasma cells, and that's how you have all of the symptoms which Joe nicely showed us. Now, once you start getting treatment, your response really matters. And even on blood work, if everything is negative, we call that a complete response or a stringent complete response. You can see down below out there, there's still quite a few myeloma cells there. And that is part of the reason why myeloma can come back again. So the deeper you go in terms of response, as you go deeper and deeper down, that is MRD negativity. And the tools we have today, we can actually look for 1 in a million cells in your bone marrow, in your blood. And if you can get to that, that then delays your disease coming back. And somebody asked the question of potentially curing. Well, getting rid of the disease as much as possible is going to set us up to get you to that curative platform for myeloma. There's other reasons to do it as well. As myeloma evolves, Dr. Mikhael has shown us very nicely that relapse does occur, but with every relapse, the myeloma can become genetically more unstable. And that's why from the beginning, it's best to try and get rid of every possible myeloma cell, and that is try and get to that MRD negativity. So the goal of myeloma therapy should be MRD negative. So there is a biologic reason. I showed you the myeloma disease burden, and also a genomic reason as to why we should be getting to MRD negativity. So the next question really then is, well, does it make a difference getting to MRD negativity? And we've looked at close to 10,000 patients here. And the bottom line here is getting to that deep, deep response of MRD negativity does translate into outcomes. You do much better if you're MRD negative versus those who are MRD positive. This has been shown also in a very large subset of patients, both in terms of disease disease control, and both in terms of living longer. So the deeper your response, the better the outcomes. And in 2025, we should be aiming for the deepest possible remission in our patients with myeloma. So before we go into the details of therapy, I do want to bring this up because this is a conversation that I think I get asked all the time in my clinic. What are the techniques and how do you test for this MRD? Unfortunately, as of right now, we are using bone marrow-based techniques, and these are two of them which I have out here. One is a genomic testing on your right-hand side, that is a sequencing platform that we have, and another one is using flow cytometry. That's also done on bone marrow. In the United States, we tend to use the genomic platform, which comes from Adaptive. That is a commonly used test, and most of us have access to that. In terms of flow cytometry, if you're living across the Atlantic, I think most patients in Europe, etc., use the flow cytometry approach. But as Joe has already told us so nicely, if we could have a test in the blood, it would make life so much easier. And we are all working very hard to get this mass spectrometry testing. There are two different methods. There's a clonotypic peptide method or a light chain method that can be used. And ongoing studies have really looked at comparing these mass spec methods with the genomic testing on the bone marrow that I've shown you. And really, if you look at this, the mass spectrometry method can in fact be even better than the next generation sequencing method, underscoring that moving away from bone marrows in the future is going to be really how we're going to be taking care of all of you. So not that many bone marrows, as Dr. Joe has pointed out, and really trying to do a more patient-friendly blood test to demonstrate minimal residual disease negativity is our goal, and it is our goal towards curing myeloma as well. All of these things which we're talking about is to try and get to a platform of curing myeloma. So when it comes to treatment now, the goals of treatment are not any different whether you're considering a transplant or not considering a transplant. And I think what we want to be moving away from in the future is this whole notion of transplant eligible versus ineligible. I think what we have to start thinking about is, am I considering a transplant or am I deferring a transplant going forward? And that's how we should be thinking about things in the care of myeloma patients, specifically when we're using combinations and have such high response rates in terms of how patients are doing. So what are the goals of treatment? When you want deep responses. With those deep responses, you want that durability of response. You want to remain in remission for as long as possible. You want to get rid of all the symptom burden from the disease itself, which Joe has talked to us about. You want to improve the quality of your life, and really you want to live as long as possible with or with the eradication of myeloma, so to speak. So I'm not going to belabor this. Marc has already shown us this. We've had lots and lots of drugs in myeloma ever since 2000, and we've had close to 20 approvals in the context of myeloma. More recently, we have a whole host of immunotherapies which are approved, and I think Joe touched on this: CAR T cells, bispecifics, antibody drug conjugates. So really, I think the future for multiple myeloma is extremely bright, and we have the audacity now to actually put in print how we will be defining cure for myeloma. And my hope is that in the next 5 years, we are going to see a substantial number of patients actually cured from this disease. And I'm going to argue even today and say that about 30 to 40% of patients are already being cured of their disease. We need to obviously do better and cure the majority of patients with myeloma. Now, it is really important that whatever you get as your initial treatment be really good and effective and control your disease as well as it can. And the reason for that is, even in the fitter patients who are considering a transplant, about 20% of patients don't see their second line of treatment. Joe showed us nicely lines of therapy, 1 line, 2 line, 3 lines. Well, your first shot at your myeloma should be your absolutely best shot, and try and control that disease and get rid of that disease so that you never have to hear back from that myeloma ever again. But even if you do, I think the second opinion, going to find a myeloma expert, is really important, because we've shown you all of the different drugs available in the context of myeloma, and reaching out to a myeloma specialist is really, really important. So, I'm going to go through this very quickly because folks have mentioned these drugs already. We were using combinations, and I think the key right now is using quadruplets. So the backbone of a proteasome inhibitor, an immunomodulatory drug, dexamethasone, and to that added on is the anti-CD38 monoclonal antibody, whether it's daratumumab or isatuximab, is the recipe for the current treatment for multiple myeloma. Now, should transplant be considered for all, and how should I prepare for a transplant? When I think about a transplant, really, I don't have that initial conversation at the initiation of your treatment. There's so much you're going through. You're trying to understand your disease. So learning about your disease, getting on to a 4-drug regimen, if you can, should be the goal. So a PI, an IMiD, dexamethasone with an anti-CD38 monoclonal antibody should be what you should be considering. And then we can talk about the transplant issue. Typically, I start having that discussion when you start your second cycle of treatment. I put down a couple of questions here. Is transplant a choice? And I do think it is a choice. It is a discussion that you have with your treating physician and really go over the data. The other thing is timing of the transplant. Not if I give you your initial treatment, and if you have sort of life-related issues where you cannot get a transplant done at that specific time, can you delay the transplant? And the answer to that is yes. Once your stem cells are collected, you can pick and choose the timing of your transplant. And again, this is a very important place where you need to have that discussion with your treating physician. Can MRD help me decide whether to transplant or not? And the answer right now, I'm going to say, is no. But if you look at the data, if you get to MRD negativity, it doesn't matter how you get there, your outcome is good. And at least in the future, we do believe that this will play a role in helping us decide whether everybody needs a transplant. We're not quite there just as yet. What about the risk of a transplant? We've been doing transplants in patients with myeloma now for close to 60, maybe 70 years. So a long, long time. We have a lot of experience with transplant. And really, there is a risk of you are hospitalized for about 10, 12 days. With a transplant, maybe 14 days. There's a risk of infections. There is risk of low counts. But beyond that, you do recover. And with every day post the transplant, after the initial 2-week time frame when you feel absolutely awful, you do get better. And in general, the risk of a transplant is extremely low. When do I start working with my care team to consider transplant? As I've already mentioned, it should be after your first cycle or so. And what do I need to prepare for a transplant? Understand what a transplant is. And I'm just going to mention, the word transplant can be a bit of a misnomer, because it's really what we do is collect your stem cells, give you high doses of chemotherapy, and give you back these stem cells. So essentially, it's high dose of chemotherapy and giving you back your own cells. So we're not transplanting you from somebody else. And that was a question of what's the difference between an autologous transplant, which is what we recommend for myeloma, as opposed to an allogeneic transplant, wherein we get stem cells from a different donor and then give them to you. So two very different things. as of today, we should be focused on your own cells, autologous cells, which we give back to you. And it's around cycle 2 or cycle 3 that you have to start thinking about a transplant. Now, where's the data for the transplant? This looks like a busy slide, but I'm just going to tell you that this was a trial called the Determination Study. All of us have participated in this. It was a large randomized trial, and it looked, in this case, 3 drugs. Everybody got 3 drugs, and then half the patients got a transplant, the other half continued their 3 drugs, and then everybody was put on maintenance treatment. If you look at the data out here and look at the progression-free survival, that is disease control, patients who got the 3 drugs with the transplant followed by maintenance did much better than the ones who did not get the transplant. But if you look at the survival of patients, there was absolutely no difference. So whether you got the transplant or not, you did just as well. And that is why it's really important that you talk to your treating physician and really decide for yourself if this is what you would like to pursue going forward. It is a choice, as mentioned. The other thing is we talked about MRD, and again, it looks like a busy slide here, but I'm just going to give you the take-home point here. Now, there were a significantly higher proportion of patients who got to MRD negativity when they had the transplant. But whether you had the transplant or not, if you were MRD negative, and this was MRD negative, 1 in a million cells by some of the tests that I showed you earlier on, your outcomes did not differ. So whether you got the transplant or you did not get the transplant, once you were MRD negative, your outcome was similar, which is why I said the future, we are going to be able to use this tool to help us decide whether I should be considering a transplant or not. There are other combinations as well. This is I showed you RVD. This is a carfilzomib containing regimen. And here again, they've shown that if you add KRD or carfilzomib, lenalidomide, dexamethasone with a transplant, your outcomes are much, much better. We've talked about quadruplets and adding an anti-CD38 monoclonal antibody to the backbone of these 3 drugs. And if you look at the data here, this is the Griffin trial. And what was done in the Griffin trial is 4 drugs like was shown in the transplant ineligible patients, RVD with daratumumab, where you see a really high response rates, close to 100% of patients respond. And if you look at the complete response rates, close to 3/4 of patients get to that complete response. So again, our goal should be that deep, deep response. And this translates into a 3-fold increase in your MRD negativity. So getting those 4 drugs is important. And if you look on your right side out there, those folks who got the 4-drug regimen did really well for a very long period of time. Lots of different quadruplets are have been studied, quadruplets versus triplets. And the bottom line is it doesn't matter which quadruplet you use, your 4 drugs is way better, deeper remissions, better outcomes in all patients. Just going to highlight the Perseus study. This is DARA VRD versus VRD. Everybody got a transplant here, and that is exactly what Marc was telling us about earlier on. We've always assumed that transplant is the right thing, and therefore we've incorporated it, but nobody's really asked the question in the context of 4 drugs of deferring a transplant. Whether we do that study or not, I'm not sure, but this is why I think having a discussion with your caregiver is really, really important. What we've seen out here is patients who got the 4 drugs did really well. And this is quite remarkable. At 4 years, patients, 85% of these patients are continuing to be in remission without hearing back from their disease. And the assumption is 7 and 10 years later, these patients are still going to be in remission, which is part of the reason I'm saying we still haven't followed them long enough. We probably cured a subset of these patients, and hopefully those patients are never going to hear back from their disease going forward. Again, highlighting MRD negativity, there's more than a doubling of MRD negativity when you go to the 4 drugs versus 3 drugs, and that is what's translating into that improvement in control of disease using the 4-drug regimen. The other really important thing is this MRD negativity deepens over time. So part of the reason why we continue therapy in you all is the depth of the remission keeps improving over time in all patients going forward. We did a small study. This was a Skylark trial, and the only reason I bring this up is, the question is, should I get transplanted? Should I not get transplanted? And here we've used a 4-drug regimen. In this case, we used lenalidomide, carfilzomib, dexamethasone with the other anti-CD38 monoclonal antibody, isatuximab. 50 patients, but the majority of these patients actually deferred a transplant. And if you look at this data set as a whole, all of them got collected. So my big recommendation for you today is, don't worry as much about should I be transplanted, I didn't get transplanted. If you're able to get a transplant with the data we have with the transplant, we would recommend a transplant. If you chose to defer a transplant, you're seeing data out here. Despite deferring a transplant, our patients did exceedingly well. They remained with disease control more than 90% of the times and did exceedingly well. So you can store your cells and think about a transplant at a later date as well. There's this other similar trial using ESA-KRD in patients with high-risk features. Again, they have included transplant in this patient population. They've also studied ESA-KRD without a transplant. And at least for high-risk disease, we do think incorporating a transplant might actually benefit patients. The core treatment algorithm in myeloma is really changing quite substantively, though. And talking about maintenance, as of right now, the one approved maintenance strategy is lenalidomide. So everybody should be on lenalidomide maintenance. And as of right now, at least most of us believe that you continue lenalidomide until progression. There are certain patients who have high-risk disease, and Joe very nicely showed us how one defines high-risk multiple myeloma with some of your genetic factors. And if you have high-risk disease, at least in my practice, I will continue lenalidomide as well as whatever proteasome inhibitor. If you're on carfilzomib, I go to carfilzomib days 1 and 15. If you're on bortezomib, I do bortezomib day 1 and 15. Now that we've moved to quads, we are continuing with the use of daratumumab. I try and give my patients daratumumab for at least 24 months, that is 2 years. After that, based on the Griffin trial, patients have discontinued daratumumab and were allowed to go back onto daratumumab if their disease became obvious again. But the majority of patients have been able to continue daratumumab. So, again, I think the data with anti-CD38 monoclonal antibodies is still to come, and there are plenty of trials which will read out in the next year or so. So we will see whether or not we need to continue daratumumab indefinitely, or 2 or 3 years of dara is going to be enough in terms of maintenance. What are the questions over the next 5 years? Well, we all understand how hard it is for you all to stay on treatment forever. But when we have tools like minimal residual disease, I do think we're going to begin to ask the question of, can I stop treatment? And those are the kinds of questions we are already beginning to use. Can we use immunotherapy? The power of immunotherapy is where the MRD negativity rate is as high as 80 and 90%. And can we replace transplant? And absolutely, those are the questions we are addressing as we are talking about today. And can we use risk-adapted approaches? Do we have to use 4 drugs for everybody? Can we have better tools to decide how to best treat your myeloma? Can we combine some of the immunotherapies, and where will we have the antibody drug conjugate that Joe has already mentioned. Some of the studies which are ongoing in the upfront study is the MRD to stop study. So we are going to be using MRD as a tool to decide when can we stop. As of right now, I'm going to say continuous therapy is the paradigm. Do not stop treatment. But these, I'm just highlighting this because for the future, we're going to be considering this, and we will be able to tell you maybe a couple of years down the line, hey, 4 years of maintenance is enough. Let's stop treatment going forward. We also questioning transplant as of right now. We have this trial ongoing, is the CARTITUDE-6 trial. Transplant versus CAR T cells, and we'll see whether transplant can be replaced in the near future. As of right now, we do consider transplant as standard of care. I'm not going to talk about side effects because Mary is going to tell us more about side effects, but there are certain things that all of you can do to prophylax against some of these side effects, and I think using aspirin, if you have a high risk of thrombotic risk, then we do use blood thinners, using drugs like acyclovir to prevent shingles when you're on a proteasome inhibitor are very, very important. Supportive care is very important in myeloma. You know, bone disease, we've talked a lot of patients present with bone disease. So I think it's important to be on a bone-targeted agent, either zoledronic acid or denosumab. It helps strengthen your bones. It helps prevent bony-related problems going forward. So all of these things should be considered in addition to your anti-myeloma care as well. The future, I think, you know, we are in an incredible time in myeloma with all of the drugs that Marc and Joe have talked about. And with that, we continue in the lab at least to continue to search for newer targets as well. And once we start combining all of these, I do think we've already made myeloma very, very chronic, but that is the first step towards cure. And as I've already mentioned, I do think we're curing 30 to 40% of patients with the 4 drug combinations. And hopefully with immunotherapies, that bar is going to go back up to the vast majority of multiple myeloma patients. So with that, I thank you for your attention, and I will turn it back to Joe.
Thank you so much, Nupur. As always, delivered beautifully. You never look or sound rushed, and yet you covered a tremendous amount of material. So thank you very much for that. It was really, really outstanding presentation, and it's invoking some great questions that we're going to get to afterwards, and you've answered so many of them that came through as well. I love your optimism for the future. I agree. I'm amazed at where we are now, even doing some of these programs you and I 10, 15 years ago. Think of how different it is now than where we were then. Well, it's absolutely my joy now to turn back to Mary, who is going to talk to us about living your best life, side effect management, and patient empowerment. Mary, you're an inspiration to many of us in what you do personally and professionally. So I'm really looking forward to this. I'll turn it to you.
Great. Thank you so much for that kind introduction. This evening, we're really going to jump into living well with myeloma and empowerment for all of you newly diagnosed patients through discussing the seasons of multiple myeloma. So on the Nurse Leadership Board with the IMF, we have the privilege of putting slide decks together for you guys. And tonight we'll go over things starting from diagnosis. And we've already heard really well about the different routes that patients can go with their treatment. So we're going to start in the winter with understanding multiple myeloma. Then we'll spring into treatment for newly diagnosed patients, and then get into our summer of success and enjoying life's bounty. Pretty fitting that we start out here in the winter and understanding your diagnosis. And just by you guys being here with us this evening, it's proof that you want to know more and be empowered to make decisions with your care team about your myeloma. So Dr. Joe introduced kind of what the disease is and how it's this abnormal plasma cell that's going to cause symptoms. And it's those symptoms that lead to diagnosis and that also lead to the CREB criteria, which often end up being a number of symptoms that you guys are that you have at your diagnosis. So just a quick reminder here, these clonal plasma cells can cause symptoms in you guys. So they can crowd out the bone marrow and you may not be making white blood cells or red blood cells normally, which can lead to anemia, or if you're not making platelets normally, you can have thrombocytopenia. The light chains that were described can cause kidney problems. And then the process of myeloma within the bone marrow itself can affect bone cells. And so I'm just gonna get through here. We're gonna build on what the symptoms are commonly for patients. And I think it's important to remember that the symptoms you guys experience at diagnosis are because of the cellular process that is behind the physiology of myeloma itself. So often patients present with fatigue, immune dysfunction, which is frequent infections, renal dysfunction, bone damage. This can be kind of life-altering for some patients in terms of fractures and then pain resulting from those fractures. And then that elevated calcium, which is one of our CRAB criteria too, which comes from the bone damage. So to speak to infections first, I mean, preventing infections for patients is paramount. Very often, a symptom is frequent infections prior to your diagnosis. And then you may even be prone to more infections because of the treatment. So it's important to remember that myeloma itself causes immune dysfunction, but then the treatment that we give you can make you more susceptible to infections. So it's very important to report any symptoms you're having to your care team. You know, we define fever as a temp of 100.4 or greater. You guys always ask, importantly, kind of how can you prevent infection? And I think early on at the start of your diagnosis, this is like more important than ever, because we want you to live life and remain a social being and be connected to your community. But we do also want you to avoid actively sick people. Good hand hygiene goes a very long way for preventing infection. And then depending on where you're at in your treatment, we may ask that you avoid crowds, you wear a mask when you're amongst other people or within crowds. Immunizations are always going to be a very important part of your general health and wellness. And depending on where you're at in treatment, we're going to be recommending certain immunizations or re-immunizations. So getting your vaccines again after you go through something like stem cell transplant or CAR T. And then Dr. Rajay briefly spoke about the supportive meds that we ask you to take while you're on your treatment. And so we'll get more into those. But medications like acyclovir are very helpful for preventing some of the common viral reactivation that we can see with your treatments. So kidney and bone health are equally important. You've heard about both of these in terms of what the CRAB features are. So often myeloma patients do present with some sort of kidney damage. So we want to then protect your kidneys throughout. So treating myeloma is the number one way to kind of prevent further kidney damage. Staying hydrated is something that's in your guys' control. It's easier at sometimes than others for you, but drinking water, I usually recommend about 2 liters of fluid a day, the majority of that being water, although other liquids do count. And then it's up to us and you guys just to be aware to avoid certain medications. So those that are commonly toxic to the kidneys, we're going to want you to avoid. Symptoms of kidney dysfunction are a little bit challenging. And so patients often ask kind of what should I expect if my kidneys aren't going to be doing well? And the truth of it is you may not notice these symptoms, but in severe, like renal failure, patients do have swelling in their feet, like profound fatigue and weakness. You may have nausea and vomiting, and you can have changes to the color and smell of your urine. But for the most part, once you've had your diagnosis and you're on treatment, we're going to be checking your labs pretty frequently with all those treatment visits. So we're keeping a very close eye on your kidney health. Bone health is really important, whether you present with lytic lesions or not. We want to keep your bones strong and healthy. And so we're going to recommend one of those bone strengthening agents, as Dr. Rajay mentioned. The most common class is called the bisphosphonates, and this is going to be most likely an IV medication that you may get once a month. You may get it once every 3 months. It is important at diagnosis too. And then alongside that is weight-bearing exercises and then adequate supplementation of vitamin D. If you have a low vitamin D level to begin with, you may need some higher doses of supplementation. And then regular doses of calcium. And by regular doses, I just mean like the recommended daily supplement of calcium and vitamin D. And those can be taken in combination. And then here we are delving into spring and treatment. And so since tonight's discussion is all surrounding newly diagnosed myeloma, and we've heard a lot about the treatments that are recommended early on, I just wanted to stress here some vocabulary that you're going to hear us using, and that is induction. So induction treatment speaks to that initial treatment for your multiple myeloma. And then consolidation, often in the form of stem cell transplant, is a secondary treatment that comes once you've had a nice response to that initial or induction treatment. And then maintenance speaks to the type of treatment that is going to be lower in intensity. The purpose of it is to keep you in the remission that you've had. Perhaps that remission deepens. But managing kind of symptoms through maintenance, and the importance of maintenance is quite important, but perhaps not as important as kind of getting you through this induction treatment. And so I usually just talk to patients about how the initial treatment is really important, because we want you not to have any further damage to your kidneys or your bones, or be suffering from infections, or have those symptoms of myeloma itself. And we've heard very well tonight about the quadruplet therapies. And so this is just another picture of that. I'm going to focus a little bit more here on the supportive medications that go along with this. So being on 3 different drug classes, and then that 4th drug class is commonly going to be the steroid. We do want you to have prophylaxis against herpes simplex virus and shingles reactivation. So that usually comes in the form of a drug called acyclovir or valacyclovir. If you have low blood counts and you seem even more susceptible to infection, we may put you on some antibacterial agents as prophylaxis. Dr. Rajay mentioned the aspirin or an anticoagulant, depending on what your risk for blood clot is. And when you are on an IMID, that risk is a little bit higher. So we're going to ask that you take one of those medications, and then those bone strengthening agents. And then the steroids. So Dr. Joe mentioned how it's nice that we're able to use less steroids nowadays, and certainly in the relapse refractory setting, that is very true. When you are initially being treated for your multiple myeloma, steroids play a really important role. So they can enhance the effectiveness of the other drugs you're on. It has a big immunosuppressive effect. But of course, steroids do come with side effects. So I think for most patients during your initial treatment, your care team's going to recommend a little higher doses of steroids in the beginning, and then hopefully those total doses can be brought down over time as we see your myeloma respond to the other drugs. It's important to be aware of the side effects of these steroids. So these high-dose steroids, it's most commonly dexamethasone, can cause irritability, can cause blurred vision, or an increased potential for cataracts over time. You can have muscle weakness. You can have changes in your blood pressure, so typically higher blood pressure, higher blood sugars. So patients who also have diabetes, we really want to pay special attention to kind of your total steroid dosing and how that's affecting your blood sugar. So I think my take home on steroids, they can really mess with your sunny disposition. Some people do like them because it gives them a little burst of energy once a week or for a couple of days every week. But it's important to talk to your care team about what your symptoms are as you start these steroids. And then it's up to us to work with you to help mitigate some of these negative side effects while still controlling kind of your treatment and having the best response that you can have. Peripheral neuropathy is a really important symptom to be aware of for myeloma patients, and especially as you begin treatment. So there are some of our treatments that can cause a worsening of peripheral neuropathy or can cause new peripheral neuropathy. And commonly that's going to be the drug bortezomib or Velcade, which is very commonly used in the frontline setting, as we've discussed. But for some patients, you do present with peripheral neuropathy, so prior to treatment ever, and maybe this is because of longstanding diabetes, maybe this is because of the myeloma or some other process. in and of itself. And so neuropathy is damage to the nerves. And typically what patients experience is kind of a coldness or a numbness or kind of this thick feeling in your toes or in your fingers. It's important to discuss this with the nurses in your infusion room and your providers as you see them. There are some things we can do to mitigate the risk for peripheral neuropathy. And if we believe it's coming from that bortezomib or Velcade, we're going to reduce the dose of that drug pretty quickly. And I think one of the benefits of us having all these other treatment options in myeloma now is that we really don't have to push for you to get Velcade and kind of push through some beginnings of neuropathy. So it's important to be aware of that. Induction treatment is important, and you may suffer some symptoms through it, but we never want those symptoms to alter the quality of your life or kind of change the course of the quality potential of your life. So please always speak up about that. There is some evidence behind neuroprotective supplements, such as the B complex vitamins, that can be helpful. Green tea is listed there, although if you are a patient who is on bortezomib, we're going to ask you to avoid green tea surrounding your Velcade. So I think the take home here is just report symptoms if you're having them. If you had peripheral neuropathy to begin with and it seems to be worsening, again, please let us know. Auto transplant, we've heard kind of the reasons to do it and the reasons not to do it. I think it's still really important that we talk about it though. And I'm going to mostly focus on kind of the logistics of it and what it looks like for a patient. As Dr. Rajay mentioned, usually around cycle 2 of your induction or initial treatment, we're going to start having this conversation with you. And if you are not being treated at a transplant center, you may be referred to a transplant center to further the discussion and kind of get all the information you can around auto transplant. It is used as consolidation, so it is best used when there is control of your myeloma already, and we want to just kind of deepen your response. And as has been mentioned, it's up to you and your care team about it. We can break it down into phases, as you see here. So kind of the eligibility or the potential for auto transplant being phase 1, phase 2 being the transplant itself, and then phase 3 being everything that happens after transplant. So both Dr. Braunstein and Rajay have mentioned that it's not necessarily like, are you eligible from a medical perspective, but is this the best thing for you? And the timing of that is probably the biggest decision. So we mention after cycle 2, which for most people is probably 8 weeks of treatment, because as is the most important thing is getting disease control. So your physicians and your nurse practitioners want to see you have kind of quick control of the myeloma to help mitigate any of those symptoms that you had and to help decrease that disease burden. And then we can start talking about the timing of transplant. Importantly, everybody's going to get full induction before proceeding to transplant if you're going to transplant early. And most commonly, that's probably about 4 cycles of treatment. The first step to transplant, though, is being able to collect your stem cells. And we know that the longer patients are on treatment, the more difficult it can be to collect stem cells. So I'm just going to stress here that ideally collecting stem cells around 4 or 6 cycles of induction treatment is probably best. It just makes it easier on you as the patient. We do have some really good drugs that can help stimulate stem cell production in your bones and make it a little easier to collect. But ideally, you're collecting stem cells, whether you're going to transplant early or not, within kind of the first 6 months of treatment, I would say. And so if you are not at a transplant center, that collection of cells is going to happen at the transplant center, and you may need to just stay locally at that center for, it says here, 2 weeks. We try to really keep people like 7 to 10 days max, and then have you be able to go back to your treatment center. And then phase 2 of transplant itself, importantly, includes that high dose of chemotherapy. So that is the purpose of the entire transplant, is getting that chemotherapy. And then you're supported afterwards, and you get those stem cells back, which just decreases the amount of time that your bone marrow is not functioning, and it kind of replenishes your ability to have an immune system faster. And then phase 3 of transplant really can be defined as happening from day 100 and beyond. And we're always going to do a myeloma disease assessment in that time frame and then talk about maintenance if you did proceed with transplant. And so this is just another way to look at that eligibility. And I think I spoke to most of it, as have Dr. Braunstein and Dr. Rajay earlier this evening. This is a little pictorial of what collecting of stem cells look like. I think it's important for you guys to see this because if you do travel to the transplant center, you probably haven't encountered this in your treatment setting otherwise. The goal of this is to collect a certain number of stem cells, and that's going to depend on your transplant center, but usually it's somewhere around like 6 million per kilogram up to 10 million per kilogram. And those are then going to get stored and frozen until you may need them. But it looks similar to a dialysis machine. We call it an apheresis machine, though, and you have a big central line in whether that's temporarily or going to be more permanent if you're going to proceed to transplant, and blood's going to get pulled out through one line, run through the machine, which only collects the stem cells, and then your blood goes back through the other line. And then transplant, as I mentioned, that whole thing is about the high dose chemotherapy, and depending on where your transplant occurs is going to kind of depend on the day and the number of days which you get it. But conventionally, everybody refers to day 0 as the day you get your stem cell infusion back. And you're going to receive the chemotherapy anywhere from 1 to 2 days prior to that stem cell infusion. And then we anticipate that you have low counts within kind of the first 5 to 7 days. You're going to then get some GCSF, depending on the center you're at, to help support your white count coming back. We see then those signs of engraftment, and then you move on to phase 3. The GI symptoms. So this slide is here after transplant because thankfully when we talk about myeloma therapy, and especially this induction upfront therapy, there doesn't tend to be a lot of nausea, vomiting, frequent diarrhea with the drugs we use. But when we get to transplant and we're using that high dose melphalan, there certainly is GI symptoms that go along with that. Very broadly, we refer to it as mucositis, and that is because the way that melphalan works, it's just a blind cell killer. So it's going to decrease, or it's going to, eliminate skin cells all along the your mucosal tract from your mouth to your anus, and you can have symptoms associated with that. So nausea, diarrhea, inability to eat, or just not wanting to eat. Most of the time when you're experiencing this through transplant, you may be in an inpatient setting and you get a lot of supportive care to help get you through this time period. And then as your cells begin to engraft, these symptoms improve. If you do experience constipation or diarrhea with any of your induction therapy, it's important for us to be aware of that as well. Sometimes the pain medicine you're taking can lead to constipation. Sometimes for people, the IMiDs can cause constipation, or the bortezomib. Also, those drugs can cause diarrhea as well, too. So it's always good. I always tell a patient when they're about to start therapy, the next couple of weeks are going to be kind of you experiencing symptoms. Please write them down, and then let's talk about them every time you're here, and we'll help you determine kind of what drug we think is causing it and what to do about it. Because as you can imagine, when you start 4 brand new drugs all on the same day, it can be hard to know what's happening. And then the post-transplant phase is really from when you have engrafted those cells and you start feeling better. If you had to be at a transplant center, so you're far away from home, this is the time period where you may be able to return home, usually somewhere between day 20 and day 30. And then the next couple of months are just all about recovering from the transplant before your disease assessment is done, and then any maintenance or like a further consolidation strategy is discussed. When you do have auto transplant, we do recommend that you have re-immunization. So all your childhood vaccine series should be done again, and that begins at 6 months post-transplant. And we wait till about 6 months just so that your immune system and the B cells so your lymphocytes that we depleted with the chemotherapy are mature enough to actually take the vaccine on and do what they're supposed to do with it, help your system further recognize that infectious disease. Okay, so none of the providers or nurse practitioners or anyone can do this, including you, without care partners. And so care partners are really essential for, I think, your whole myeloma journey. And this is true for anything that is challenging in life. We all need people. And as Dr. Mikhael mentioned, patients who have good support and participate in support groups do better. So it's important that your care partner is aware of kind of everything that is happening during transplant, but also all of your myeloma treatments. And then care partners, it's important for you guys to take care of yourselves too. So we don't talk too much about that in this version of the presentation, but please take care of yourselves as well. And then maintenance therapy is, as I mentioned, what happens kind of after the transplant, or if you don't transplant, it happens after that initial induction and consolidation therapy. It's always going to be lower intensity, and the goal is for like you being able to tolerate it for a long period of time. And as Dr. Rajay mentioned, it still is indefinite the way most of us are treating these days, but there's clinical trials ongoing that maybe will help guide us and know kind of when a patient can stop maintenance therapy. I think it's important to just remember about maintenance. I mean, in your initial treatment, we really ask you to kind of, and we try to get all these doses of treatment in, and you may not feel well every single time. In the maintenance setting, that is probably a little different. So this is a time and space where you should be getting back to your life more fully. And if you need to hold the maintenance because of an infection or because of a trip or something, just talk to your providers and care team about it. The goal is to keep you on maintenance, but it doesn't have to come at any cost to you. And so it's important also for us to be aware or know that kind of your quality of life is what you feel like it should be while you're on this maintenance therapy. And here we are getting into the heat of summer already, and you're starting to be an empowered patient here. So what does that mean to be an empowered patient? It's really important to ask questions, and often you're going to have questions that come to you when you're not in clinic or when you're not seeing your provider. So it's important to write these things down, talk to your family about them, talk to your care partner about them, and then bring them back to the clinic when you're seeing your providers. It's really important to understand your labs. I think it's important if you don't want to understand your labs in the very beginning, then that's okay. But at some point in time, you'll be more empowered if you do understand the labs. And I think you know the type of person you are. So if it is uber important to you to understand every single change in your labs, then just ask those questions. And if you are a patient who just kind of wants to know the broader theme of what's going on with your labs, just ask that way. You know, there are certainly engineers out there who come to us with Excel sheets of their hemoglobin over every single week during induction therapy. And so it's important, if that's what matters to you to understand, then let us help you understand that. And that really speaks to the communicating with your healthcare team, and then speak up if you feel like something isn't going the way that you have, that it has gone before, or that you think it should go. And I love that we put in this like blood draw thing, because quite often a patient, I see them in clinic after their blood is drawn and they're like, but they only drew 2 tubes. They didn't draw like the 8 tubes that I usually have before my whole disease assessment. And then that is what helps me capture that there was a failure in the lab system, and those labs were ordered, but they weren't what was actually drawn. So important to know those things. And of course, develop your support network, and the IMF is here to help you do that. Pain. So it's, you know, we're 3 seasons in and we're just talking about pain. Often you present with pain at diagnosis. Sometimes you develop pain after treatment's already started. But the most important thing about pain is that you let us know about it. And it, you know, pain does compromise quality of life. And this is true across any sort of healthcare need or any disease state. We want you to be comfortable. You have less stress if you have less pain. So whatever it takes to kind of help manage your pain, that should be the goal. Treating multiple myeloma is really a multidisciplinary effort, and we as myeloma specialists rely just as heavily on pain specialists and orthopedists and sometimes neurosurgeons. And there are a lot of alternatives to opioid medications for pain management these days. So please speak up about your pain and symptoms you may be having. One of the goals of treatment is to prevent further complication and so to prevent further pain. So hopefully this is addressed long before the summer season of your diagnosis, but certainly something that is true throughout your treatment. And then fatigue. It is the most common reported symptom at diagnosis and really probably throughout all of treatment. There's a lot of things that cause fatigue. There's a lot of people who have chronic fatigue or fatigability that don't have multiple myeloma or cancer. And so I think understanding kind of what your baseline of fatigue was and where you would like it to be. I think fatigue is most concerning when it limits your ability to do activity, limits your ability to do kind of everyday events. One of the annoying things about fatigue is that the best way to manage it is with activity. So of course there's medications that can help improve fatigue. If we correct an anemia or correct your pain, that can help reduce your fatigue. But sometimes the answer to fatigue is movement. And so it's not the easy answer, but it really is the best answer overall. Depression and anxiety can come along with a cancer diagnosis. They can come along with experiencing chronic symptoms like fatigue, like chronic pain. And so just know that as myeloma specialists and as your care team, we are interested in helping manage all of this and improve on these symptoms where we can. And there are medications that can help improve upon these symptoms. There are certain therapies or support groups, speaking with a therapist, cognitive behavioral therapy, acupuncture. There's all sorts of what we say alternative, although I would like these not to be considered quite so alternative therapies that can help improve upon this for you guys. And then cultivating a care network. We've talked about this a little bit. And here we're just seeing kind of really the proof in the pudding that there's increased longevity with people who have strong social ties. There's improved adherence to medical treatment. There's an increased sense of purpose and life satisfaction. I mean, we and you treat your myeloma to reduce your symptom burden and keep you safe and living kind of the fullest life you can live. So we don't treat numbers, we're treating people, and the goal of the treatment is to have you be able to live your life in the manner in which you want to live it. So it's certainly a very important part of all your treatment. And then the fall. This is my favorite season of life. We get to have pumpkin spice in almost everything. And there we see those beautiful pumpkins. So Dr. Mikhael had mentioned this too, but keeping, there was a time, and when I first started in myeloma, which was I think a long time ago, but where we didn't worry too much about like general health screenings because life expectancy was not quite as long as it is now. But now it is very important as ever that you maintain good blood pressure, you have a healthy cholesterol, we reduce any risks for cardiovascular disease. You have a mammogram if you're in that, if you're a female or a male with risk factors and you're in that age range, you have regular colonoscopies. So general health screening and health maintenance is very important. Depending on where you're at in your diagnosis, treatment, or treatment setting in general, sometimes your myeloma team might be able to take care of this for you, but it's always good to maintain the relationship that you have with your primary care provider. That way, they can work with your myeloma team in maximizing your health and wellness. And then plentiful sleep. So I mentioned this briefly when answering that question. Sleep is so important. It's so important for really all of us. But for you guys on new medications and with a new diagnosis, it's really important to maximize sleep. And admittedly, we are going to give you things that make this hard to do, namely that dexamethasone or there's steroids that come with treatment can certainly interfere with sleep. Anxiety can interfere with sleep, depression, pain, all of these things don't make sleep easy. So anything you can do to improve your sleep health is going to be really important. Sometimes this is doing a sleep study and going on CPAP or BiPAP. Sometimes this is reducing some medications. Sometimes it's adding a certain medication. I've had patients respond really well to cognitive behavioral therapy that improves their insomnia. So I think insomnia, which is inability to sleep, is a symptom that a lot of human beings walk around with, and it's not very well talked about. Take advantage of the fact that you're a patient who's going to be seen very frequently if you have multiple myeloma. So bring up that insomnia, even if you've had it your entire life and it's not related to this. This is a good time to take on any interventions or lifestyle changes that can be improved upon so that you are sleeping better. And then we'll just close off with all the resources that the IMF has, which is just amazing. There is something for everything. One of my favorites is Understanding Your Lab Values. It's a really nice booklet to read at diagnosis. And then also know that you're going to get the hang of the words we use and the new vocabulary and the structure of early treatment. It's a pattern and you will get used to it. So it's important to utilize resources and speak up when you have questions.
Awesome. Thank you so much, Mary. And what a great way to end. Dr. Mary has walked us through 4 seasons and has brought us to questions, and lots of questions have come in. So thank you, Mary. I just always appreciate not only what you present, but how you present it and the experience you have. I won't get into a battle with you as to how long you've been doing myeloma versus the rest of us, but it's amazing to see the evolution here. So we're now going to move into our last set of questions. I know that many of them, there's lots of them. I think we're going to be able to get through the lion's share of them over the next 10 to 15 minutes, and then we'll wrap up. But I do want to remind everybody that we're here to answer your questions, and you have multiple ways to do so. Obviously, you've got the chat tonight, but if you're listening to this afterwards or you still want some time to think through your questions, you can always call the info line. You can always use any of our social media channels and just use the hashtag AskTheIMF, and Dr. Joe will try and get to answer your question in different ways. Don't forget, at the myeloma website, myeloma.org, we have a chat bot, Myelo, and Myelo can be your new friend. We had a patient write to us the other day and said that Myelo is her new boyfriend. So I'm not sure if Myelo identifies as a man or as a woman or how they identify, but you can identify with Myelo any way you wish, because it has the opportunity to answer questions that is gathered from the myeloma website. But let's dive into the questions. We've had so many great questions. Some of them we may not be able to get to, but I do think that we will have the opportunity to cover a lot of them. Dr. Rajay, let me start with you, because you talked a bit about this, but just for clarity, when you're treating a patient on maintenance therapy, will you use MRD to guide the discontinuation of their therapy? i.e., will you stop treatment based on a patient being MRD negative?
Yeah, no, great question. And I showed you the study that we're doing, the MRD STOP study. So I don't think it's ready for prime time just as yet, Joe. As of right now, we still believe in continuing patients on therapy, whether it's lenalidomide or the anti-CD38 and the proteasome inhibitor. But hopefully the future is going to allow us to look at MRD testing and allow us to stop. There's an ongoing study, the dramatic study, as you know, and we will see the data from the dramatic study. This was a very large study wherein patients were given lenalidomide and an anti-CD38 monoclonal antibody, so daratumumab, and MRD was used to stop treatment after a couple of years versus continue treatment, and that is going to allow us to figure out whether using that tool is the right approach. But as of right now, don't stop your maintenance treatment.
Yeah, thank you for saying that. I mean, it's such a high priority, right? I mean, every patient wants to be on nothing. I joke and say, not as my favorite therapy. It's covered by every insurance company. Everyone is fully adherent to it. Everybody loves being on nothing, and I would love to be able to do that, but we have to do it rationally. Marc, real quickly, do all myeloma cells have BCMA and CD38 on their surface?
Yes, I mean, BCMA and CD38 are very highly expressed on plasma cells. In fact, we don't necessarily measure their expression before we provide treatments that target those surface markers. But when we perform bone marrow biopsies, CD38, for example, is used by the pathologist to identify plasma cells. So they're very highly expressed and very specific in the bone marrow to plasma cells.
Excellent. Absolutely. Completely agree. Mary, if someone had no bone involvement when they were first diagnosed, does that mean that they'll never have bone involvement?
I wish I could say yes to that, but I don't think it necessarily means you will never have bone involvement. Typically, the first or second relapse may present similar to your diagnosis, but over time that can change, and so there is always that risk, which is why imaging remains important.
Yeah, I completely agree. That's why that sort of you got to re-image the whole crime scene, right? Get all the features, all those pieces of information together. Dr. Rajay, for you here, someone is saying they're a year out from transplant, but they still have very low white blood cell count and platelets. When is a stem cell boost called for?
Yeah, so, I don't think a stem cell boost is necessarily called for at this point in time. I think the patient is probably on some kind of maintenance treatment as well. Most of us use lenalidomide maintenance. That can drop your counts as well post-transplant. So I think working with your clinician and figuring out what is causing the low white cell count is going to be important. And then secondly, you might need to dose adjust your lenalidomide maintenance in that setting so that you're not neutropenic or your platelets are not low going forward. But yeah.
Excellent. I think it also just underscores a key point is that, myeloma patients are allowed to have other things that are going on as well that may not just be from their disease. Someone asked, for example, a question of, is there hypothyroidism caused by their lenalidomide? We don't really think of it as causative. It could be that because some of the side effects that we see from lenalidomide are similar to thyroid disease, the diarrhea, the fatigue, that sometimes we test for it and we find that people are hypothyroid and they were likely coexistent phenomenon. So in a sense, the lenalidomide may have unmasked it, but not necessarily caused it. I love this question. I have a friend who's been living with myeloma for 23 years. Is that unusual? In one way, I want to say yes, it was. If you'd asked me that question 10 years ago, it was very unusual, but now it's starting to become more common. We know many, many patients that have lived over 20 years, and we trust that they will live even more. Marc, I got to ask this question because it's one of the most common questions we've gotten in the last week at the info line. Should we be worried about what's going on with the measles? I don't want to say I want to call it outbreak, but with the measles cases that were detected.
So, I think we all have a little bit of triggering after the pandemic about any new outbreak of an infection. And so with regard to myeloma patients, we are always keen on any form of susceptibility to infection. And, one of the first things I tell patients in general is, always call us if you have a fever or any signs of infection that we discuss. With regard to measles, I think that if someone were not vaccinated, they should certainly pursue that. It is true that some of the treatments we give for myeloma suppress the response to vaccination, but not entirely. So it's still worth getting vaccinations like your flu vaccine and measles if you're not vaccinated. Now, if you're very immunocompromised, for example, right after a stem cell transplant, before you go for that, revaccination that typically happens 6 to 12 months after, and typically for live vaccines, that's not until 2 years after a transplant. I think you have to be very cautious, especially if you're in an area where now measles is more prevalent as an outbreak. So, the stories are developing in terms of, what the status of this is. It seems to be confined to certain areas, but I think it's certainly something we have to pay more attention to, especially in our patients who are immunocompromised.
Yeah, I agree with you. It's a challenging situation. I do wonder, the MMR, the measles, mumps, rubella vaccine being an attenuated live vaccine, if if we're always going to be as strict on the 2-year mark, if there may be some flex there, if there are more cases. And so it's an evolving point. And I think we might dedicate one of our future Ask Dr. Joe questions around this so we can dive in a little bit deeper. But thank you so much for that insight. Mary, is it possible that acupuncture will raise our immune system to fight and kill myeloma cancer cells?
Wow, I don't think I have any science behind an answer here. I do know and believe that acupuncture improves stress levels, and it probably, which in turn can improve your immune system. I don't know that I would say it directly leads to killing of myeloma cells. I think of acupuncture as a wonderful adjunctive treatment or therapy to receive in addition to the anti-myeloma therapies that you're on. And it often, most commonly, really helps patients with nausea, pain, insomnia. So it's definitely worth seeking out if you need it, but I don't think it should ever be in place of any other treatment.
I think that's extremely wise answer and very appropriate. I mean, I think we hear all the time, don't we? Oh, doc, shouldn't I take this immune booster? And we got to be careful. As I showed from the start, myeloma is a disease of the immune system. Let's not boost the wrong part of it. Sometimes people think a natural therapy must be good because it's natural. And living here in Arizona, I say snake venom is natural. Like I don't mean to be facetious about it. I just mean to be cautious that we have to think these things through. Several questions I think Dr. Rajay answered so beautifully in her lecture around MRD. I'm so thankful. People at the IMF will think I planted this question. I did not plant this question, but several of them actually have come in saying, what is the value of dexamethasone? What does it do? How much do we need of it? Back in the early days when Dr. Rajay and I were treating multiple myeloma, steroids were a centerpiece of our treatment. They were the big boost. Sometimes I remember when I trained in Canada under Dr. Keith Stewart, we would just give dexamethasone as induction therapy before transplant. We didn't even have thalidomide available to us back then. So we know that dexamethasone has an anti-myeloma property. It also has an anti-nausea property. It also has an anti-reaction property, meaning to reduce the risk of reaction from some of the drugs that Dr. Braunstein explained to us earlier. So we know that Dex has a role, but now that we're gone from doublets to triplets to quadruplets, we're feeling that the active role that dexamethasone plays is less. And also it tapers off with time because as you continue dexamethasone cycle after cycle after cycle, its effect is less, but its side effect is higher. I sometimes draw a picture in the clinic of booster rockets on the shuttle. And I say, Dex are like the booster rockets, really helpful for those first few cycles, but then we need to drop the dose. And so I commented on a paper recently Dr. Banerjee published. We wrote an editorial called Down with Dex, where probably the maximal impact of Dex is really in the first few cycles. And many studies are now even being designed to start to taper them down. And similarly, for the person who asked about dexamethasone with drugs like daratumumab or isatuximab, for the vast majority of patients, the real benefit is that first cycle. In my clinic here, we don't give pre-meds with steroids after the first cycle unless someone has had a reaction in that first cycle, and we've not seen an uptick in reactions. Obviously, every patient has to be looked at uniquely, but I think we are looking at a day and looking ahead to using less steroids over time than we used to for many of those reasons that I've outlined. Mary, you talked a bit about keeping hydrated. What other types of liquids are okay to drink? Any caffeine-free soda or sparkling water, is that okay?
They all sort of count if you're purely just counting ounces that you intake, but soda is not good for us, and nor is caffeine-free soda. It doesn't make it any better, nor does diet soda make it any better. So I think if you should limit those, but when you're talking about just like pure intake, we do count those things.
For transplant patients that have lost their sense of taste or smell, Dr. Rajay, will that come back?
It does come back, absolutely. A couple of months and post couple of months, you actually have your taste sensation back in the majority of people. And one thing I do want to highlight, dexamethasone, if we can decrease that, it's the dex which causes issues with taste. And I think most of us like to use less and less of dex, as Joe, you nicely pointed out.
So you've joined the Down with Dex movement, Nicole. Awesome.
Absolutely.
I heart you for that. That's wonderful. Someone's asking, can we have the slides from tonight's presentations? Absolutely. You'll be able to download them when you go to the Myeloma website, where you can download this video as well. So yes, the slides are going to be available to you. Marc, is it common to do a double stem cell transplant, one right after the other?
Oh, that's a complicated question, but a good one at that. So the short answer is that it may be indicated in certain unique instances. For example, someone has high risk or ultra high risk disease. There may be some indication for what's called a tandem transplant, where you do 2 transplants more or less within the period of a year. They have done randomized studies. The Stamina study is an example of one such study where they looked at this in the setting of patients who got 3 drugs, the VRD induction, and didn't really show a benefit for most patients, except perhaps a small cohort of high-risk patients. So there are some institutions at Arkansas, for example, where they do favor tandem transplant. But I think in the setting of modern therapies with, daratumumab and lenalidomide maintenance, I think it's generally falling out of favor.
I think that's a fair answer. Absolutely. I do think they're very limited situations, and maybe, I think there still is, and I wish I could understand this, that there are still very occasionally, but there are still some patients who, for whatever reason, we try different induction regimens and the response just isn't optimal. Somehow their disease seems to be very responsive to that high-dose melphalan. And I guess that may be a consideration, but I agree with you, with the exception of maybe 2 centers, Arkansas you mentioned, and the other one I won't mention, but rhymes with Mackensack, seem to really be just teasing my friends who work there. But I would say the majority of us across the U.S. are significantly reduced in their use of tandem or double transplant. We're coming to the end now, so let me bring 2 last comments. One question, one comment. This is a great question. A family member was diagnosed with myeloma, came from a local hematologist. She referred us to learn from a myeloma specialist, but offered a consult with them, but that the generalist would continue to administer the treatment. Is that common? Should we directly work with our main provider as the myeloma specialist? And I'll speak to this because this is my practice almost every day. I work, of course, for the IMF, but I continue to have a clinical and academic practice here in Arizona. And interestingly, here in Arizona, we don't have very large academic institutions. So a lot of care is delivered by the community oncologist. In fact, I would argue that approximately 80% of myeloma patients in this country are primarily treated in the community. And I think we can develop an excellent partnership with the myeloma specialist, where most of the patients that I'm involved with, they're being given their treatment, the ESA VRD or DARA VRD and the different combinations we mentioned tonight in the community, but they're checking with me on a regular basis to get advice. And sometimes people think, I'm cheating on my oncologist by going to see you. They don't feel that way. Doing this for over 20 years, I can only think of a few general oncologists who are upset by it. More often than not, they love the input from the myeloma expert. It becomes a team working around the patient. Mary described that beautifully, right? We want a team of people around you. It takes a village to care for myeloma. And so I would encourage you that, yes, this can be open, clear communication between the community oncologist and the myeloma specialist and yourself. And then lastly, I just want to read this beautiful comment that someone wrote here. Thank you so much for being so tender and gentle. My mom was just diagnosed last Friday and we met with the specialist today. So kind of you to be encouraging and informative. I mean, that's exactly why we're here. So thank you very much for the individual who made that comment. Please engage with us at the IMF. We're happy to help you and walk you through this journey more fully as you just described with your mother just being diagnosed. We want to help you there. Well, at this point, I'm going to just remind people that you can go to myeloma.org and go to the section on publications and videos. You'll be able to not only rewatch this riveting video, but you'll be able to download the slides there if you wish. And please, as I mentioned, provide feedback to us. It's so helpful in the way we set this up, the length of time, the topics we cover. And again, I'll just put another plea in for sending questions to us. We tried to answer the lion's share of what was about 50 questions tonight, some submitted before and another about 40 or 45 here with the multiple questions in a single box. But if you have questions, please reach out to us. We would be very happy to do that. And don't forget that we have just kicked off Myeloma Action Month. What is your action going to be? And it's not hopefully just listening to a video. I guess that's a good thing, but we really want you to take it to your community. Go to myelomaactionmonth.org and we'll provide more information and options for you there. Thanks again to our sponsors, GSK, Johnson & Johnson, Karyopharm, and Takeda for supporting us tonight. And I always like to end with reminding people our vision and our mission. I already mentioned the vision earlier today, but the vision is a world where every myeloma patient can live life to the fullest, unburdened by the disease. And this was brought to us and led by our former president and CEO, Yelek Baru, who taught us the importance of that unburdened by the disease. And our mission for many years has been to improve the quality of life of myeloma patients while working towards prevention and a cure. We hope the day will come where that fraction of patients that Dr. Rajay spoke about earlier of cure can really be a significant fraction in the majority, if not all of our patients. I won't read all of our core values to you. You can read more of them at the IMF's website. But we work, of course, internationally in multiple programs. Education, research, advocacy, and support are the four pillars of the IMF, and we'd love to interact with you in every way that we can. No, don't forget to subscribe to our YouTube channel and to these multiple means of social media. The IMF is very social media savvy. We would love to connect with you and follow us along so that you can learn more about myeloma as we go through. So with that, I'm going to take a moment to thank our doctors this evening, Dr. Mary, Dr. Marc, Dr. Nupur, if I can call you that in the spirit of Dr. Joe. We appreciate these three individuals and for the care they have for patients, for the knowledge that they have, and importantly tonight for how they've conveyed that to us all. So thank you very much to the three of you. Thank you for our amazing meetings and support team that have made this happen. And with that, we will say goodnight and trust that we'll see you again in the near future. Thanks very much.